It is a pleasure to welcome you all to the Sir Gangaram Hospital CME for general practitioners. As general practitioners, you're often the first point of contact, the first diagnostician, and the first decision maker. Medicine today is evolving rapidly, not just in terms of treatment, but in technology, early interventions, and multidisciplinary care. Staying updated is no longer optional, it is essential for delivering timely, effective, and patient centered care. Today's CME has been thoughtfully designed to bridge cutting edge advancements with everyday clinical practice. From artificial intelligence and newer diagnostic tools to preventive strategies, early recognition of disease, and integrative therapies, each session aims to offer practical takeaways that can be applied directly to your practice. We are privileged to have an excellent panel of experts from across specialities, each bringing deep clinical experience and academic insights. I encourage you to actively engage and reflect, take back learning points that enhance both confidence and clinical outcomes in your practice. Welcome, everyone, and thank you for being here. I'm Dr. Kopal Rohatgi, and today, with this first session, we have a very interesting session on early intervention in chronic pain. Chronic pain significantly affects the quality of life and functional outcomes. Dr. Mithlesh Mishra, who's in the Department of Anesthesia, will discuss the importance of early intervention in chronic pain patients. This emphasizes timely referral and multidisciplinary approaches that general practitioners can integrate early in their practice. For this session, our chairpersons are Dr. Rakesh Saxena. Sir, I would request you to please join us on stage. Dr. Ajay Agarwal, sir, please join us on stage. And Dr. Praveen Suman, ma'am, please join us.
Good morning, everybody. For this session, we will be talking this. Dr. Mithlesh will be talking about the early intervention in chronic pain. As a private practitioner, we all know that a patient usually has one of the three complaints. Either he has got pain, he has fever, or he is bleeding, for which he seeks medical advice. Now, this pain part is usually not well addressed. They keep on postponing and they don't seek early intervention for that. For the same reason, Dr. Mithlesh will be talking about early intervention in pain, because if the pain is allowed to persist for long, it will have a lot of psychological problems and other economic issues and all that. So I will request Dr. Mithlesh to start his talk.
Thank you, sir. Thanks for the kind introduction. Good morning, everyone. Respected chairpersons, I'm thankful to Sir Gangaram Hospital Trust Society, Board of Management, Chairman, the organizing team led by Dr. Manchanda, sir, Dr. Neeraj, for continuing this CME. This is the topic specifically chosen as the first topic of the day. Whatever subject we are practicing, whether it is surgery, whether it is medicine, whether it is ortho, more than 80% of patients seeking medical advice coming to any healthcare professional for one type or other type of pain. As a doctor, it's our duty to find out the pain generator. Living with pain, chronic pain, reduces everything, reduces quality of life, reduces your productivity, your earning, government earning, overall life. The topic is early intervention. We say it early intervention because according to protocol of treating chronic pain, we should first do the conservative part, we should give the medication. But when you are sitting at Delhi at a quaternary tertiary hospital we see the patient who is coming to you for any chronic pain has already taken medication from one or another person for years to come. They have some sort of NSAID induced nephropathy, liver problem, everything before they reach you. You cannot just add on to the complication. Now we are having so many advanced technique by which we can find out the pain generator, treat it in a way that patient is no more dependent upon the medication only. We'll see one by one. We all know, whether it's globally or India, more than 50% population is suffering from some type of chronic pain, whether it is a back pain, whether it is knee pain, whether it is trigeminal neuralgia, whether it is fibromyalgia. We'll see one by one. In India, it is more than 51% at any one point. Knee osteoarthritis, most of us would be treating them. Issue is not only osteoarthritis. Even when the patient is not ready for knee replacement, when surgeon is not ready for knee replacement, there is no so much deformity, no fixation, but the life is hell. The patient could not sit for the toilet, he is not able to do his normal daily duties. What we give normally, we give some sort of NSAID. How it will help, we don't know. How muscle relaxant will help and for how many days we can give muscle relaxant, we don't know. Even when a patient is ready for total knee replacement, post surgery he needs some pain relief so that he can practice the rehabilitation part. He can do the quadriceps exercise, he can build the muscle so that he is no more dependent upon whatever wheelchair or some sort of power sharing devices. What we can do in knee pain, whether it is because of osteoarthritis or post surgery, apart from regenerative therapy, PRP, prolotherapy, first and foremost thing is we block the nerve supply. Knee is supplied by some genicular nerve, which are purely sensory nerves, except the lateral inferior, where we suspect that peroneal is closer by. Other nerves you block, the pain relief immediately it reduces to more than 75%. Patient dependence on the drug will be gone. Patient will start moving, start doing exercise, helping in rehabilitation from next day. And it's not a block that you just give local anesthesia and come out. We have radiofrequency neurolysis. Most of the nerves now we are not practicing alcohol or phenol neurolysis, that nearby structure will be affected. We are having radiofrequency which just make the some sort of neuromodulation on that particular nerve. We are very specific. We first sensory stimulate that nerve to see our needle at correct place. We put local to confirm the pain relief, and then we do radiofrequency, both conventional. In all sensory, we do conventional. Pain relief lasts for 1.5 years. Even on motor nerve, even on nerve which are painful and mixed nerves, we can do pulse radiofrequency, neuromodulation. Patient pain relief will be there for more than 6 months. Headache. In our setup, our family, our friend circle will see migraine, cervical headache, some sort of association with depression. What we do? We keep on taking medication for migraine for years to come, knowing that it is so much harming our own body. Mostly we see patients are coming to us with a MRI brain, that since headache was there, we have done MRI brain, it is normal, which will come normal in 99% of population. They have done nothing. If we search for the pain generator in headache, we are having intervention. In cervical headache, it is associated more than 40%. If you give cervical epidural, if you block the occipital nerve for facial pain with frontal headache, if you block the sphenopalatine, dependence will be gone. Patient will not be afraid that anytime aura will start and I will have to stop whatever I am doing. And it is dangerous also. If you can reduce the migraine headache, if you can reduce the cluster headache, even to 70% or 80%, the quality of life improves. We stimulate that nerve, localize that nerve, and then do the radio frequency. It is one of the worst pain anybody can imagine, trigeminal neuralgia. What we give, some form of carbamazepine, pregabalin, gabapentin. A patient comes with all the altered bone marrow picture, with altered liver function. How much dose you can increase? We don't have any limit. I have seen people taking 1200, 1400 without any relief. Unless until we do some microvascular decompression to the compressing artery or some intervention, the life is hell. That patient is not able to do daily chaos. They are not able to shave. They are not able to open the window of car. One injection of searching that particular nerve and a radio frequency ablation will lead to pain relief for 1.5 years. We have done more than 1,000 cases. The pain medication either has stopped or at the minimum dose. For everything, hyperhidrosis, for any neck pain, some form of headache or sympathetically mediated pain, stellate ganglion block, even for uncontrolled arrhythmia where cardiologist is told that this storm is not directly affecting your heart, we can do a stellate ganglion block, and it is a wonderful block. It is very helpful. Previously, for acute pancreatitis, chronic pancreatitis, or GI malignancy, we were doing only celiac plexus block, where we were searching for that either posteriorly or anteriorly and giving alcohol or phenol. Right now, we are going one step ahead. The celiac plexus is formed by the splanchnic nerve. Alcohol neurolysis will last for 6 months or 1 year, plus it will affect the nearby structure. Splanchnic nerve, greater and lesser splanchnic nerve, radio frequency, targeted block will give relief in all these conditions for more than 1 year, and that too, it is reversible. You are not cutting that nerve. Patient will have the sensation within 6 months to 1 year. Whether it is phantom limb pain, breast pain, or eye pain, you target the nerve supply of that area. Before doing the amputation, you block that nerve, stop the central sensitization, and it works a lot. Back pain, it is one of the worst to treat. It is very difficult to treat. Almost all the structures in the spine are pain generator. This is a term which we commonly use. Suppose a patient is having both pain due to disc and facet. We have treated the disc, we removed the disc, but the joint pain remained. I'll just take 1 minute more. So patient pain has not relieved. Patient will say the surgery has failed. I have paid 2.5, 3 lakh rupees for a pain which is, though surgery was correct, we have removed the same disc. We tried our best to treat, but the pain generator was 2. We have targeted only 1. In such scenario, going for another surgery, we can block the nerve supply to the facet joint. We can do the medial branch block, and the patient will be able to do the daily activity from second day. These are the some advances. We are giving platelet-rich plasma to disc also for regeneration. If nothing helps, spinal cord stimulation, though a costly option, but it does wonder in all these chronic pain scenarios. Hypogastric plexus block for any pelvic pain, menorrhagic period pain, testicular pain, vulvodynia. One procedure of 30 minutes will give effective pain relief for years. The worst pain to treat is fibromyalgia, head to toe pain. Patient will have pain everywhere. What we normally do, these patients are taking painkiller for one or another on daily basis. In this also, if you treat the acute pain early, search for the pain generator consciously, these patients lead to normal life. Take home message is all the pain, chronic pain are treatable. Only thing is we have to be more aggressive in finding out and giving long lasting pain relief to all our chronic pain patients. Thank you so much.
Thank you, Mithlesh. So the take-home message for all of us sitting here is early referral. You should not, if you see that the therapy is not having many effect, so it should be referred to. There must be the pain maybe somewhere else, and the patient should be referred to a higher center as quickly as possible.
Thank you, Dr. Mithlesh. It was an excellent presentation. I would like to add one thing. Although these procedures you use for pain relief, but I think these can also be used for things like spasticity and all, especially in children
True, ma'am.
with cerebral palsy, where as a developmental pediatrician, I see day in and out. So these are very useful procedures which can be used.
We are doing it, ma'am.
Yeah, thank you so much.
Yes.
Yeah.
Yes.
When patient should be referred to you?
As early as possible, before kidney stop working.
Because a lot of, I don't think they're coming.
We all
early.
know, sir, whether in a chronic knee pain, whether chronic back pain, patient is either fit for surgery or not fit for surgery. Surgeon has seen and taken a decision that this patient will not be much beneficial from surgery. Then what about the pain? We have to do something. Only medication will not help. And patient need multimodal treatment, physiotherapy, he need to exercise, he do normal daily work. For that, we need to help. Asking a patient to do back pain exercise from day one with severe back pain, it is practically impossible. We have to treat first, then only they can go for some sort of physiotherapy.
But I think you must be getting patient almost late only.
We are getting late only, sir.
Late only because
Patient
they
has, they have gone to so many centers before they come to us.
Any question from the audience?
The ablation life is for 1 year or some more.
Which
then
one,
you
sir?
have to repeat it.
Which one, sir?
Ablation, whatever the ablation we are doing.
Sir, normally, yes. If we do thermal ablation, it lasts for 1.5 years. We have cool radio frequency also, which is a bit longer. But yes, our mind setup is like we have to repeat it in 6 months to 1 year. But in more than 40% of patients, once you break the pain cycle, there is more than 50% chance that it will not recur. Suppose for facet joint and other shoulder joint, if you do one time, once pain cycle has break, it may not come, and the chances is more than 50%.
Approximately average charges to the patient.
Depending upon, suppose knee pain, genicular, we are having general ward also for non-affording. We do it for free also. But on an average, a single room patient pays something around 50,000-60,000 rupees.
Is it covered in insurance?
Every procedure of pain is covered under insurance, sir, by all the companies.
Thank you.
Thank you.
Yes, ma'am. I'll just come to you, ma'am. Once again, one question is here, sir.
About PRP, this procedure, how many sittings you give in a particular case? Can it be repetitive?
Number of sittings?
Yes, sir. Normally also we need 2-3 sessions of PRP. Suppose plantar fasciitis, patient is having pain while walking. We give 1 or 2 settings. But if it is responsive, then only we repeat. Suppose we have given once and nothing happened. It is a regenerative therapy. With pain relief, it is acting in healing also. So patient may not need any further pain relief intervention or medication.
That regeneration is everlasting.
Most of the cases, sir. Everlasting means we target for 4-5 years only. Sir. Ma'am, phantom limb pain, if you block the nerve supply to that area before amputation, that is the best. Okay. If not, it is a multimodal. We block the sensory supply to that area with some form of medication, antidepressant. We have to continue at low dose. Mirror therapy and everything does have a role, but yes, if you do the nerve block, sympatholysis of that area, it is helpful and it works for more than 6 months to 1 year.
Okay. I think, thank you, Dr.
Thank you,
Mishra.
sir. Thank you.
Thank you.
Thank you so
Thank
much.
you.
Thank you, sir.
Thank you so much, sir, for such an interesting session on chronic pain. And now we move on to the next. We move on to the next session. Uh, Dr. Archana D. Arya, who's a senior consultant in pediatric endocrinology, is going to tell us about the red flags in pubertal development, enabling early identification and appropriate referral. I welcome you on stage, ma'am.
Good morning, everybody. And now we move on from pain to puberty, which is a very important part of childhood as a child develops physically into an adult. And it is very important for all of us to identify abnormal puberty in children. But before we move to abnormal puberty, let's take a quick look at normal puberty because we have to understand what's normal and what's abnormal. So, puberty has got two arms, adrenarche and gonadarche, and both these arms are controlled by the hypothalamus in the brain. The hypothalamus produces two hormones, the corticotrophin release hormone and the gonadotrophin release hormone. Both these hormones act on the pituitary gland. Now, the CRH or the corticotrophin release hormone produces ACTH. This goes and acts on the adrenal gland. The adrenal gland produces DHES, and this is responsible for the pubic hair, axillary hair, body odor, and acne. And this is called the hypothalamic pituitary adrenal axis. So, if we have a child who has early development of pubic hair, axillary hair, body odor, acne, etc., or abnormal appearance of hair, we have to evaluate this axis. Now, coming to the second axis, that is the gonadotrophin release hormone. This acts on the pituitary, and the pituitary produces LH and FSH, and these are our gonadotrophins. These act on the ovaries in girls and the testes in boys, and they result in enlargement of the testes and ovaries. And in response to these, the ovaries will produce the female hormone estrogen, estradiol, which is responsible for the breast development, development of the uterus, the periods, and advancement of the bone age till growth stops. And the testosterone is responsible for the androgenic effects in males. And this is called our hypothalamic pituitary gonadal axis. And if we have a child with early development of these features or there is a delay, this is the axis that we are going to evaluate. And this is the true puberty. True puberty is presence of breast enlargement or thelarche in girls and enlargement of the testes in boys. So, breast in coming to starting with puberty in girls. Now, breast development is or thelarche is the first sign of puberty, which and along with this there is a growth spurt, and this is usually followed by what we call as adrenarche, that is the appearance of pubic axillary hair along with acne and body odor. Menarche occurs about 1.5 to 2 years after thelarche, and this is followed by slowing of growth. So, the last point at which we can help a child with early puberty with their height is when they've almost reached menarche or if they've just had, but the earlier we identify them, the better the response will be. The onset of normal puberty is approximately 8 to 13 years in girls. Precocious puberty is onset before 8 years or menarche before 9.5 years in girls. Now, precocious puberty is more common in girls and very common between 6 to 8 years and is mostly idiopathic at that time. But before 6 years needs immediate and detailed evaluation because there could be a pathology. Coming to delayed puberty in girls, if there is no breast development till 13 years or no menarche till 15 years, it's called delayed puberty, and this is less common in girls. Coming to puberty in boys, the first sign is testicular enlargement, again followed by adrenarche, increase in the penile size. There is a growth spurt later in puberty in boys, followed by hosening of voice, facial hair appear, and that marks the end of growth. The onset of puberty in males is a year later, 9 to 14 years, with a mean of 11.5 years. Precocious puberty is onset of testicular enlargement before 9 years and it is often pathologic. So, again, detailed evaluation is needed. And delayed puberty is no testicular growth till 14 years of age, which is more common in males. Then we have some other variations in normal puberty. Sometimes sexual hair may appear before thelarchy or testicular enlargement. That means adrenarche occurs before thelarchy. That is fine as long as it's in the normal age range. Some girls can have unilateral or asymmetric breast enlargement. That is also very common. 60% of males will have gynecomastia, which is during the third stage of puberty usually, but sometimes it can occur earlier and is more common in overweight boys. Ultrasounds are usually not required for these children because tumors and abscesses are not common. Unless you find something really abnormal, we don't need to do routine ultrasounds in these children. These are all normal variations. Other abnormalities of puberty, which are a little less common, are arrested puberty, that is, no menarche in a girl for 3 years after onset of thelarchy, or a non completion of puberty by 4 years in males. Heterosexual pubertal development, even rarer, where there is virilization in females due to congenital adrenal hyperplasia or tumors, or feminization of males due to rare adrenal tumors and androgen insensitivity. Now, coming to the clinical assessment of puberty, that is the most important thing. We can't do everything by just looking at the child, looking at a girl and saying, oh, yeah, she has breast development, she could have fat, or looking at the testes or penis and say, oh, this is small or big or whatever. So, Tanner staging should be done. It's very important in every child. We should be able to differentiate between fat and breast tissue in girls because chubby girls will always have a little bit of breast tissue. So, we have to look for progression. Testicular volume should be measured with an orchidometer in boys. More than 4 ml is considered to be pubertal. If the penile size seems small, the stretch penile length needs to be measured in them to distinguish it from an embedded penis. And if the circumference of the penis is normal, it is usually not a true micro penis. A true micro penis would have a very thin circumference. Now, if you see here this picture of this young boy over here, the penis looks so small over here, which and the parents are worried. But if you actually measure this child do a stretch penile length with a ruler, you will see that this child has a normal penile size. And these are orchidometers which we use to assess puberty, because when puberty just starts, it's very hard to identify it visually or by just examining the testes without this. Looking at a quick look at the biochemistry of puberty, the gonadotrophins LH, FSH, and sex steroids testo and estradiol are undetectable from 6 months till onset of puberty. So low levels do not signify hypogonadism. Also, the initial secretion of these hormones is at night, it's pulsatile. So we must do early morning levels to make a diagnosis of early or delayed puberty. And if they are borderline and we are not sure, we usually do a GnRH stimulation test. Also, the onset of puberty correlates with the skeletal or bone age of the child. So, to do a good bone age is also very important, because if the bone age is delayed, puberty will be late, and if it's advanced, then puberty will be early. So, these are the basic things we have to look at in a child who comes with a complaint of a pubertal abnormality. Now, I'll go quickly through the rest of my slides. What is precocious puberty? I've defined it. It could be central, which is GnRH driven, as we saw, due to central causes like tumors, etc., or could be idiopathic due to hypothyroidism. Peripheral precocious puberty is GnRH independent. It is due to autonomous sex steroid production from the testes, ovaries, or the adrenals, seen in CAH, testotoxicosis, tumors, and McCune Albright. And then we have incomplete variants like precocious thelarchy and precocious adrenarche. In progressive precocious puberty, you will see thelarchy in girls and testicular enlargement in boys. These children are tall, there's growth acceleration, bone ages are advanced. In central, all the levels will be high, LH, FSH, testosterone or E2. And in peripheral puberty, LH, FSH will be low, and the sex steroids, testosterone and estradiol will be high. And the effect of precocious puberty is well summarized in this slide. This is a 5-year-old girl who is pregnant, the youngest girl to get pregnant. She has short stature and early reproductive capacity, which are the two main side effects of precocious puberty. So they should be referred earlier. Now, premature thelarchy, one of the variants in this, you will find only isolated breast development, usually occurs before 2 and after 6 years of age. There is no growth acceleration, and all our tests, bone age, the hormones, and ultrasound are normal. In premature adrenarche, there is isolated sexual hair, more common in girls, and again, you should do DHES and 17 OHP, and these would be normal, but we should rule out non classic CAH. Coming to delayed puberty, this could be more common in boys. It is more common in boys. It could be physiologic, constitutional delay of growth and adolescence, transient due to malnutrition or chronic disease, or pathologic, as in permanent hypogonadism. How do we differentiate? If we have high levels of LH, FSH and low levels of testo or estradiol, it means that this is called hypergonadotropic hypogonadism. It means that there is gonadal failure, and these children have to be treated. If we have low levels of all the hormones, that is LH, FSH, and the sex hormones, it could be constitutional delay, it could be transient, or it could be hypogonadotropic hypogonadism. That means the hypothalamic pituitary is not working, and we need to screen these children for a cause. So, what are the red flag signs where we have to refer a child to a pediatric endocrinologist? That is early puberty, delayed or arrested puberty in boys or girls, advanced pubertal changes in short children. If you see a short girl with menarche, or change in voice in a boy who's not too tall, it means that they need to be attended to immediately. Time should not be wasted. If you see any virilization in girls, such as clitoromegaly, voice change, facial hair, feminization in a boy, or if there is prepubertal gynecomastia, last slide, they should be referred right away. Children who are showing rapid growth, headaches, they have a history of tumors, radiation, malignancies, visual changes, polyuria, and polydipsia should be evaluated urgently. No time should be wasted in referring these children. Thank you.
Any questions from the audience? Any questions from the audience?
Yeah, so we usually don't evaluate. If we are clear that this child has just developed gynecomastia during puberty, we don't need to, we just check for the puberty. If the puberty is normal and it's correlating with it, we do not evaluate them at all. If we have an obese child, which he may have had gynecomastia from the beginning, earlier. And if the parents are confused, then we would evaluate. Then we would normally we do the liver functions, we do the hormones, or if it is prepubertal, it's the same. We do a beta HCG for any tumor, we do the estradiol for estrogen secreting tumors, and we do a DHES for any adrenal tumor. So those are the. If everything is okay, the child is pubertal. It will yes, it resolves in a lot of them. The ones who are thin, it will resolve. But if a child has had gynecomastia for a very prolonged period of time, which is mostly in the overweight ones, or sometimes it's familial, or they just have a tendency to accumulate fat, and wherever there is more fat, there is local conversion into estrogen. So they develop some breast tissue. So the longer is the gynecomastia is there, the lesser is the chance that it will go away on its own. And no medication is found to do wonders with that. So the final treatment would be plastic surgery after puberty is completed. We don't intervene before that because there can be a recurrence risk is there. So we wait, give nature a chance to settle things. But if it doesn't work, the only time we use medication is if there's a lot of pain in that area. Sometimes there's a lot of tenderness over there. So usually that also settles down. They just need some counseling. It only happens on touching. But if required, then tamoxifen trial can be given just for the pain. But nothing, none of the medications, there are a lot of trials, they don't do wonders in reducing the breast tissue.
Ma'am, can you, sometimes we see a lot of patients. The girl is having a menarche at 9.5 or something like that. And a lot of parents, they are very much worried. We normally say it's normal, you don't need to do anything. So, will in any circumstance we should start the treatment if they're not worried?
Yeah. So if a girl or boy, if they have early puberty, precocious puberty, and they are tall, and their predicted adult height is normal. They're tall, they're going to stop growing sooner, but if they have a normal height, we do not need to treat, period. Menarche or no menarche, they do not need intervention. If some of them have very slowly advancing puberty, we don't treat them also. The only time we treat precocious puberty is if the final height is being affected, and sometimes in special children who cannot deal with periods, which I think
Yeah.
Praveen must be familiar with. That is the only other indication where we will arrest precocious puberty. It's so common in girls, and we don't treat more than 20 to 30% of these girls. Most of them can get away without treatment. And if they have already reached menarche, the outcome is not going to be very good, even if we treat them. But if they're abnormally short, if they're going to be like less than 4'9", 4'10", and the bones have not started fusing, then you can give a trial with GnRH analogs and sometimes add growth hormone. It does give them an extra 2 to 3 inches, and they at least reach an acceptable height. They won't be normal, but at least a little better than where they are. And there are studies to show that there is some benefit with that.
Will you like to add growth hormone also?
Depends. If they're very short and they're post menarche, then yes, we would add. Otherwise, no.
Otherwise, no.
Not as a routine. No, not at all.
Ma'am, the biggest, the clinching evidence is growth spurt when they come to us.
Pardon?
Short, those who are with precocious puberty,
Right.
the biggest clinching evidence is growth spurt.
Yes, yes.
And bone
so
age.
the point is that when they have a growth spurt, nobody comes because the parents are so happy that my child is so doing so well. My daughter or son is taller than the rest of the class, so they're very happy and they don't actually come for help. 90% of people still come post menarche, when they can connect that much that, yeah, now she's had a period and she may not grow, and that's when they come to us most of the time, unfortunately. But if these things are picked up right ahead of time, and the only way they'll be picked up is if a child is examined for their puberty at every visit. That has to be done by all pediatricians and physicians as far as possible.
And in fact, especially for the special needs children and children who have disabilities, because it has been seen that there are 6 to 7% more chances of having precocious puberty in these children as compared to the normal population. And in fact, Dr. Archana, I would like to add on in this also, the role of plastic pollution these days. There is a lot of literature for precocious puberty. We have done a lot of studies also that the plastic is broken into nanoplastics and microplastics, and these plastics carry a lot of endocrine disruptive chemicals in the body and has effect on the HPA axis, leads to early precautions. Yeah. So all of us are, in this sense.
Yeah.
So we have to be very careful and taking care of all these pollution. We are talking about air pollution. I think plastic pollution is also leading to precocious puberty.
There are two endocrine disruptors which have been, confirmed as far as we know for gynecomastia, etc. One is lavender. Some of these lavender containing things, and tea tree oil, which was used very often for diabetics for their, finger pricks and all. They have found that these are endocrine disruptors and they should be avoided as far as possible.
Should be avoided in all this.
Ma'am, any role of junk food like additives in foods and all this precautions?
So, there is, we know they all affect, but, these two are the two confirmed things. Otherwise, but when you're eating junk, you're usually overweight or obese, and it is a well-known fact that overweight and obese children will enter puberty a little earlier than average. Their bone ages are usually they're a little taller also, and their bone ages are also a little advanced. But by and large, I've seen we don't really end up treating most of them because their bone ages are good. But yes, that is a known fact. Yeah.
Thank you.
Thank
you, ma'am.
Thank you, Dr.
Thank you so much for the chairpersons and for the speaker for such an enlightening session. Now, before we move ahead, I would like to request all the participants to scan this QR code. We have a poll at the end of each session, and I would like to request you to complete the poll for this session. So at the end of each session, I would request you to complete the poll with that session which is attached. Okay. As we move on, it's no active. Okay. Arya? It's there? It's there. So it's there. It's showing on the screen as well. So for our next session, I would like to request our chairpersons, Dr. Arun Gupta, Dr. Alok Agarwal, Dr. Neeraj Manchanda, and Dr. S.N. Jha sir to please join us on stage. Our next session is by Dr. Raghav Seth, who's an associate consultant in the Department of Interventional Radiology, and he's going to talk about BPH. It is a common yet impactful condition which affects a lot of aging men. And Dr. Raghav will introduce us to prostatic artery embolization, a minimally invasive and alternative that is changing management paradigms.
Good morning, everyone. I am Dr. Raghav Seth, consultant interventional radiologist from Sir Gangaram Hospital. So today we'll discuss how we as interventional radiologists can help in this condition, very common condition, that is the benign prostatic hyperplasia. Just a second. Yeah. So we all know it is a very, very common problem, and with a high prevalence, of course, with quality of life and economic consequences. So more than 50% men are affected more than 60 years, and more than 80% are affected above 80 years. So, but the important part here is that the part which is taking more and more importance these days is the patient priorities, and most of these patients are interested for preservation of the sexual function, which is a primary driver for seeking the MIST. These are the minimally invasive surgical techniques. So we all know about the treatment landscape. First is always the conservative medical therapy. Then next are these mists, and ultimately the surgery or TURP is the which was the gold standard till very recently. So the decision drivers are efficacy, side effect profile, and of course the rapid recovery which the patients want, and preservation of sexual function. So just a brief introduction, then I'll come to the indications and how which patient should be referred, how it should be done. So we'll discuss, and of course the one case at the end just to show how we do this procedure. So basically PAE is a minimally invasive solution. It stands for prostatic artery embolization. So it is an endovascular approach. Very simply said, what is done is under angiographic guidance, we take femoral or radial artery access and we enter into the prostatic arteries that are branches of the internal anterior division of internal iliac artery, and we block these arteries. That leads to the ischemic necrosis of the prostate gland, and ultimately the size decreases and the symptoms resolve. So the main mechanism is ischemic necrosis. So this is a short video by which you will understand what is happening here to improve the symptoms of BPH, and strong point is of course preservation of sexual function. So as I mentioned, radial or femoral puncture. Under live fluoroscopy, we guide the catheter into the prostatic arteries super selectively and then inject these embolic particles to block them completely. That leads to ischemic necrosis, shrinkage, and resolution of the symptoms. Now, this is an important slide to decide or what are the ideal candidates or indications for this. So very simply said, in a basic way, any symptomatic BPH who is having moderate to severe symptoms, so there is an IPSS score, International Prostate Society score, more than 8. So in simple terms, any patient who's having symptomatic lower urinary tract symptoms because of BPH and conservative management has failed is a potential indication for prostatic artery embolization. Of course, if they want to prioritize the preservation of sexual function, or otherwise also they are higher surgical risk candidates because of anticoagulation or very large prostates where TURP cannot be done. So the indication of PAE will even increase further because these are not contraindications for prostatic artery embolization. So only few absolute contraindications are active infection, suspected malignancy, which are there in other procedures as well. Rarely severe atherosclerosis if we are not able to enter the arteries, technical factors, those are rare. And relative if the gland is very small, less than 30 cc. So these are the main contraindications. The workflow is like this. We take the vascular access, we navigate into the prostatic arteries, as I mentioned. A very critical step is the cone beam CT. So we are very fortunate to have this technology in our institution. Basically, it is an advancement in which a form of CT called as CBCT is integrated into the fluoroscopic system, because of which we can verify that we are actually into the prostatic artery and we can minimize non-target embolization. I'll show this in the subsequent slides. Then we embolize it with particles. Hemostasis is achieved. Observe the patient for few hours and either same day or next day discharge. No catheter requirement. So these are the benefits of these procedures. Multiple embolic particles and other technical points are there, but most of the studies, they say that 300 to 500 microns. are the standard, and this is what we also use in our practice. Technical success rate in literature as well as in our practice is actually very good, more than 90-95%, with good predictability, and cone beam CT guidance even increases it further. Now we have to prove the results with evidence, literature, that is a norm. So that has there is high level of data to support prostatic artery embolization. 6 major randomized controlled trials have been done with multiple prospective studies, and follow-up data that we have till now is 10 years data. So I'll just discuss these RCTs very briefly. This is from British Medical Journal 2018, 12-week outcomes. So in summary, if I tell you what they are trying to say here in this RCT is that the symptom score, if we compare the gold standard, that is the surgery or TURP, versus prostatic artery embolization, there is no significant difference. Flow rate is slightly better in TURP, but safety profile is far better in the prostatic artery group, and of course that is a strong point. Ejaculatory dysfunction or sexual preservation is far better in the PAE group. That was 12-week outcomes. This is 12-month outcomes. They find that all symptom score, flow rate improvements, everything is, there is no significant difference, and safety of course far superior in the PAE group. Also versus combined medical therapy, that is the famous PARTEM trial 2023 from Lancet. They say that of course combined medical versus PAE is far superior, not only in symptom reduction but also in the ejaculatory and sexual function preservation. So overall summary in the meta-analysis is that what the patient will feel, the symptom score, everything, no difference with the gold standard. Flow rate, prostatic volume, theoretically the technical factors favoring TURP, but adverse events, hospital stay, and preservation of sexual function is far better in the PAE group. Now there were concerns about durability, retreatment when this treatment started a decade ago, but again long-term outcomes have been proved. So 5 years clinical failure rate is around 20%. That means 80% of the patients after PAE will not require any retreatment. Even if they require repeat PAE, can be done. It is safe, effective, and even surgery, if someone wants to go surgery after the procedure, it is feasible. But 80% of the patients will not require any repeat procedure. Overall adverse events are very rare, 2.5% major adverse events, and that too no persistent sequelae, no transfusion requirement, no, and catheter free. Sexual function I have been mentioning again and again, that is a strong point of PAE versus TURP or even medical therapy. So that is ejaculatory preservation and erectile function is far superior after PAE. So that is the American Urological Guidelines latest statement 40. What they say exactly is PAE may be offered for the treatment of LUTS performed by clinicians trained in this interventional radiological procedure. So it formally recognizes PAE even in the urological pathway, and it of course emphasizes the importance of procedural expertise. It must be done only by trained IRs. And as far as our IR guidelines, consensus guidelines say, we definitely consider it for moderate to severe symptom patients who are poor surgical candidates, or even if not poor surgical candidates, with the preference to preserve ejaculation. So ultimately, this is the whole summary of the evidence-based discussion, that symptom relief for the patient will be similar, no significant difference whether they go for TURP or PAE. De-obstruction, flow and volume slightly better in TURP, but safety and sexual function far better in PAE. So this is how the clinical decision pathway should be done. If the priority is rapid de-obstruction, maximum de-obstruction, and patient is accepting the sexual side effects, we can go for the surgery or TURP. Whereas if patient is prioritizing sexual function, safety, gland is very large, or he's a high surgical risk candidate with anticoagulation, then PAE is definitely the first option. A very short case that I would like to show you here that we have done recently in our department. 60-year-old male, he was on medical therapy for BPH for 2 years, but still worsening for the last 6 months. IPSS score was 18, that is high, and prostate volume was huge. So 310 cc prostate. You can see these ultrasound images here. Serum PSA was raised, so that is concerning, and that is why we ordered MRI pelvis, and ourselves did the transrectal ultrasound guided biopsy. So trus guided prostate biopsies we routinely do in our department. It proved it to be benign, so there was no malignancy, so no contraindication, and patient was taken up for PAE. A right femoral access is taken. So we have crossed onto the left side here, and you can see the internal iliac runs here, anterior posterior divisions. So this is a small just dot which you can see where the laser pointer is actually the microcatheter, and with technological advancements we have even microcatheters with caliber of 0.5 millimeter. So that is the distal most that we can enter. So here you can see this is the prostatic artery. On the left side, further super selective, this is the blush. So this black thing which we can see in the delayed phase is actually the brush of the left hemiprostate. This was the cone beam CT which I was talking about, that we use routinely in prostatic artery embolization. So you can see here only the left prostate is opacified, and there is no other contrast anywhere else in rectum or anywhere else. So we are sure, we are safe, we are not embolizing anything else apart from prostate. This is the injection of the embolizing particles, that is the embospheres, small particles. This is the post-embolization angiogram. You can see all other arteries are exactly the same as they were before the embolization, only the prostatic artery is not seen now, and the blush of course has vanished. Similarly, the procedure is done on the right side, injection of particles and the post-embolization angiogram. So this patient at 3-week follow-up, IPSS from 18 to 9 and prostate volume from 310 cc to 140 cc. So more than 50% reduction, and symptoms far and great improvement in symptoms. So these patients become catheter free if they are catheter dependent, and overall IPSS score and all the problems which are associated with the LUTS are mostly resolved. So this is our interventional radiology team at our hospital, Gangaram Hospital. And if you have any questions or any queries, I'll be happy to answer. Thank you.
That is not a very small volume.
Not a very small volume, but as I mentioned, technically the symptom relief or the dynamic obstruction which is there, urethral obstruction, which is causing the symptoms, is resolved in more than 90-95% of the cases.
So to clarify this, I think the size of the prostate doesn't matter. A person who is having 100 cc prostate will have not symptoms, but a 60 cc prostate will have symptoms. So the concept is to relieve the obstruction rather than just looking at the prostate size. So that is more important.
Is it not that you are postponing the problem for a year or two only?
No.
So the data has shown that the results we have till 10 years.
Average cost of the procedure, sir?
Average cost is around 1.5 to 2 lakh.
It is
covered under all insurance policies.
Sir, in TURP, we are getting multiple pieces to be diagnosed for the carcinoma. But what, just you said you will do the biopsy before your procedure. You will hit a single area.
No, so I'll clarify.
Sometimes we miss whatever the biopsy we are doing.
Yes.
But sometimes, honestly speaking, we miss the carcinoma. But in TURP, we are having multiple pieces to be finally diagnosed. If we do this procedure, then how we will see only the metastasis later on. There is no way to diagnose finally. Your comment, sir.
So the prostate biopsy is first. There is a protocol to exclude the malignancy, the contrast MR, and then, if required, biopsy. Let's your point about getting the tissue pieces, the TURP. So we have to understand what we are getting from the tissue of TURP is the central zone where the malignancy doesn't develop. It develops in the peripheral part. So it's not that when we do the TURP we have a good chances of picking up the malignancy.
And just one more thing. So these days we are not hitting just one part. What we are practicing in our institution is TRUS ultrasound, transsectal ultrasound guided prostate biopsy, extended 12 core. That is the latest guideline that is followed even internationally. So we take 12 core means 6 from right, 6 from left. Extended 12 core, if there is any suspicious part, we take from that also. So apex mid part base right, apex mid part base left, peripheral zone, transitional central if required. So we take sometimes we take as much as 20-25 cores also if we are not sure, but most of the prostate is covered. That is our institutional protocol. So missing CA prostate is very rare, very, very rare.
So what are the technical difficulties you face during the procedure?
Technical difficulties, yes, these arteries are very small and tiny and prone to spasm. So we have our own techniques using nitroglycerin, vasodilators, using, as I mentioned, using smaller microcatheters, and with procedural expertise, the chances of not having technical success are very less now. Thank you.
by maintaining the sex life, BPH is controlled automatically, is it not? That helps in control of BPH, sex life.
I think there is no correlation of BPH with the sexual dysfunction. So it is meant for patients who are high risk patients, especially the procedure can be done even those who are on dual antiplatelets or even those who are anticoagulants also.
Okay. Thank you, Raghav, for such an eye-opening session on a new procedure. And we move on to the next session for the day. Hyperbaric oxygen therapy is increasingly being explored across various specialties, and our center offers it. Dr. Shweta Gogia will outline its current indications, evidence base, and referral considerations for general practitioners. Welcome, ma'am.
Good morning, everybody. So, after such enlightening topics today, we are here with another very interesting topic, that is hyperbaric oxygen therapy. Oxygen, you know, is the lifeline for all of us, and it also helps us to healing under pressure. So, we're going to talk about the applications of hyperbaric oxygen therapy for all of us. So, basically, it is defined as a mode of medical treatment in which the patient is entirely enclosed in a pressure chamber, and the patient breathes 100% oxygen at pressures which are greater than 1 atmosphere. It has been described as a medicine to treat basic pathophysiological processes and their diseases according to the textbook of hyperbaric medicine. If we talk a little bit, how did it all start? It started way back in 1662 when a domicilium was designed by Henshaw for treating hyperbaric air. Mind you, at this time, oxygen wasn't even discovered. Oxygen was discovered about 100 years later in 1775 by a scientist named Joseph Priestley, and it was named oxygen in 1777. But this gentleman, Henshaw, he designed this domicilium for treating a multitude of disease, where he pressurized the chamber with air and then he unpressurized using bellows. It was 200 years later, in 1937, when it was first used for decompression sickness. And then later on, it started finding its application in the field of medicine. Since 1970, the Underseas and Hyperbaric Medical Society has been giving instructional courses, research work, and guidance for the use of the hyperbaric oxygen. So normally, we all know that we breathe air, and air contains about 21% oxygen, which is bound to hemoglobin. Any injury or disease in our body decreases the body's ability to transport oxygen to tissues, or there can be an increased demand, or there can be an increase in distance that the oxygen must travel from the capillary to reach the cells. Hemoglobin carries majority of oxygen. So at 100 ml of blood, it carries 19 ml of oxygen, which is bound to hemoglobin, which is 95% saturated, and only 0.32 ml in plasma. Now, if we are giving 100% oxygen to somebody, then hemoglobin is going to bind to 20 ml, but the concentration which is now going in plasma is considerably increased. Now, according to the laws of physics, the solubility of gases, once we are giving the gas under pressure, the solubility is going to increase rapidly, exponentially. Talking about how is it going to help? There are two primary mechanisms of action. One is hyperoxygenation. So there is an increase in dissolved oxygen in plasma as a result of increase in partial pressures of arterial oxygen. And second is there is decrease in the bubble size. So when the bubble size decreases, it is directly proportional to the increasing pressure. So the mechanism of work increases, especially in cases of decompression sickness. The secondary mechanism of actions described are vasoconstriction, neoangiogenesis, fibroblast proliferation, leukocyte oxidative killing, toxin inhibition, and antibiotic synergy. How are you going to deliver this? It is basically utilizing 100% oxygen, and this oxygen is given at a higher pressure than 1 atmosphere, usually between 2 to 3 or 2 to 4 atmospheric pressure. Maximum tolerated in 95% of the patients is about 3 atmosphere. It can be carried out as a monoplace chamber, and there is a multiplace chamber. The procedure is that the patient is placed in the chamber. The chamber is compressed gradually in about 10 minutes. The patient is kept in the chamber for about 60 to 90 minutes, and then the chamber is gradually decompressed. So there are monoplace chambers. This is the monoplace chamber, which is there in our institution now. And these are small, and these are designed to accommodate only one adult individual, which can be lying in a supine or a semi-recumbent position. The pressures reached are up to 3 atmospheric pressure with 100% oxygen being delivered. And the high flow oxygen is usually via the hospital supply. The advantages of such kind of chambers are they are very cost efficient. There is no risk of decompression sickness. They're portable, less space is required, and there is no risk of iatrogenic decompression sickness. But there are certain disadvantages, that is, the patient is isolated. So if the patient is not very responsive, or if the patient needs assistance, then these kind of multi-place chambers are more advantageous. These can accommodate up to 18 patients at a time, and they can also utilize higher pressures up to the tune of 6 atmospheres. The advantages here are that constant patient attendance and evaluation can be done since more room is available, and the medical personnel are also, they can enter the chambers. Here, the hyperbaric oxygen is being administered through separate individual masks, and not the entire thing is not pressurized. But it requires higher capitalization requirements. There is risk of cross-infection and major space requirement and higher operating cost in such kind of facilities. Talking about the indications, according to the Undersea and Hyperbaric Medicine Society, there are various indications now, starting with air or gas embolism, carbon monoxide poisoning, and carbon monoxide poisoning, which is complicated by cyanide poisoning, clostridial myositis and myonecrosis, decompression sickness, enhancement of healing, especially in diabetes, exceptional blood loss, anemias, intracranial abscesses, necrotizing soft tissue infections, refractory osteomyelitis, delayed radiation injuries, skin flaps and grafts, thermal burns. And according to the European consensus, additional indications are surgery and implant in irradiated tissue as a preventive action to prevent rejections, sudden sensory neural deafness, neuroblastoma stage 4 as a radiosensitizer, post-anoxic encephalopathy, and limb reimplantation. There are certain contraindications, absolute contraindications, one being untreated pneumothorax, and the other being use of certain drugs, such as bleomycin, cisplatin, doxorubicin, and sulfamylon, where these drugs have to be discontinued before the therapy is initiated. The relative contraindications being upper respiratory tract infection, a COPD, congenital spherocytosis, eustachian tube dysfunctions, asthma, pregnancy, claustrophobia, seizure disorders, and hypothermia. So now, how is this working? How does this show its magical effect? So we all know that according to the results of International Diabetes Federation, there are 415 million people worldwide suffering from diabetes, and 78.3 million are from Southeast Asia. India, it is the second largest worldwide after China in the diabetes population. So diabetes has become increasingly prevalent and demands better care. So diabetic wounds, especially in lower extremities, which have failed to respond to the conventional therapy, this becomes a life-saving, a limb-saving procedure for all these patients. As you can see on the screen, exposed tendons, refractory osteomyelitis, patients facing digital amputation. So after 20 to 30 sittings of hyperbaric oxygen, you see a remarkable results in all these patients. Delayed radiation injuries. We also know that another major epidemic that we are going to face in 2050 is about 35 million new cancer cases, which is a 77% increase from the estimated 20 million cases in the year 2022. The rapidly growing global cancer burden reflects both population aging and growth, as well as changes to people's exposure to risk factors, several of which are associated with socioeconomic development. So with these alarming numbers, we know that we have to be prepared for the treatment-associated risks. So the treatment-associated risks such as radiation necrosis, osteoradionecrosis, radiation cystitis, radiation proctitis, enteritis, all of these can happen to all the patients. Radiation-induced soft tissue necrosis. So it plays a very, very major roles in all these patients and shows a dramatic improvement in these patients and improving their quality of life. Going to the radiation necrosis, which can happen to the flaps and grafts, again, it makes a miraculous response in all these patients. Why is it happening? It happens because it promotes greater tissue strength, rapid tissue growth, tissue integrity is stronger, and it enhances the growth of new blood vessels. Radiation sensitization, this is a major benefit of hyperbaric oxygen therapy because the tumor cells, they are 3 times more resistant to radiation than the oxygenated cells. So by overcoming this resistance and allowing radiation to penetrate and cause lethal damage to DNA, we can really make a difference in all the patients who have these kinds of cancers, such as cervical cervix cancer, bladder, rectum, head and neck, esophagus, and brain. And it becomes even more important if it is administered immediately before the radiation therapy is initiated. So it significantly reduces the mortality and it significantly decreases the recurrence. Other scenarios, total knee replacements. This was a child which we had recently who received hyperbaric oxygen therapy, and we were able to save the limb. And all these, another important thing is the sports injury. We have seen China is showing a remarkable increase in use of hyperbaric oxygen in all their athletes. Traumatic brain injury, where it is basically inducing neuroplasticity, increasing stem cells in the blood, and increasing the amount of stem cells which can be given to the brain to damage the tissues and help them regenerate. Important because I am a ENT surgeon, HBOT in sudden sensory neural hearing loss. It shows remarkable results. I can just show you the results here. A gentleman presenting to us with complete, profound sensory neural hearing loss in left ear was given 8 sessions of HBOT. Later on, you see that the results are remarkable with the patient just having mild SNHL now in left ear. Another gentleman having moderately severe sensory neural hearing loss in left ear, 8 sessions of HBOT, normal hearing. Talking about complications, you can have certain complications such as alveolar hemorrhages, hemoptysis, pneumonitis, but it can be managed. And sometimes temporary myopia, claustrophobia, and very rare oxygen toxicity. So the take-home message is HBOT, it can be a new friend for all of us. The indications are evolving. Wound healing, diabetic patients, cancer patients, vascular injury, brain injury, burn patients, graft patients, additionally sudden sensory neural hearing loss, sports injury, and post-implant complications. So it is a boon to all of us and we should use it to the fullest capacity. Thank you so much. Yes, please.
Honestly speaking, how better or the survival rate or your efficacy in post-traumatic fat embolism, number 1. Number 2, how it is better for the high pressure BiPAP system?
High pressure BiPAP system. So first of all, in cases where there is COPD or the patient is having a lot of respiratory issues, we do not recommend putting them under so much high pressure. We have always to, first stabilize their respiratory component and then only we can subject them to hyperbaric oxygen therapy. Second thing, you talked about fat embolism. So it has a major role in fat embolism. It has a major role in cerebral artery embolism. So, but you have to recognize these patients and you have to subject them to hyperbaric oxygen therapy when the time is apt. So, but you have also to take care of the, if the patient is having accelerated hypertension or having other, complications such as pneumothorax or is having other problems which could, wherein the hyperbaric oxygen could exacerbate the conditions. You have to basically look the patient in a whole, as a whole, because this thing is not localized. It is going to act on the entire body. The entire patient is going inside the chamber and everything is acting everywhere. So you have to be very careful about how you're choosing your patient, when you're choosing the patient in the course of the disease. And then is when, if you give this therapy, it can show you miraculous responses.
So his question was how it is different from BiPAP.
Oh, BiPAP. BiPAP is different, sir. This is basically 100% oxygen and it is being given at a pressure which is more than 1 atmosphere. We gradually increase the pressures to about 2 and then 2.5, and then 3 atmosphere. It is a highly pressurized chamber, just like you feel while you are traveling in a plane. So while the plane is ascending and descending, if you sometimes sit in the chamber, it is just like you ascending into the plane, you reaching your height and then descending as we decompress the chamber. So 100% oxygen is being given, and it is being given at a pressure. You are being pressurized in that chamber so that more oxygen is pushed into the soluble phase, into the plasma, and more of that oxygen is basically given to the areas, it is transported to the areas where there is inflammation, or there is requirement for neovascularization, or where there is infection, or where there is requirement for sensitization such as radiation, where there is hypoxia, basically.
Thank you, Dr. Shweta, for such a wonderful talk on hyperbaric oxygen therapy. I will just summarize that it is another armamentarium in our treatment. It is a multifaceted approach. It is not only the treatment, but it is an adjuvant treatment, and it have the wonderful results if we use it judiciously and cautiously. Thank you.
Thanks.
Thank you, Dr. Shweta.
Thank you so much, ma'am. It was truly a novel session. And now we move on to the next session by Dr. Tinku Bali Razdan, who's a senior consultant in the Department of Ophthalmology. Ma'am is going to talk about cataract surgery today, how it has changed and what are the new things we must know, and reinventing the old days from glass lenses to now such light lenses. Ma'am, please welcome the stage.
So, good morning, everyone. It's such a pleasure to see you all here this morning. And I'll be giving you just a very brief and simple overview of cataract surgery as we do it today. So, cataract is a clouding of the lens, the clear lens inside the eye, and cataract surgery is one of the commonest surgeries that eye specialists would do. Cataract surgery has evolved remarkably over the last few centuries, actually. It started off with couching at the time of Sushruta, went on to ICCE, that is intracapsular cataract extraction, extracapsular cataract extraction, phaco with peribulbar block, and now topical phacoemulsification. So just to give you a quick overview of the surgery, so here we make a small incision. This is a 2.2 millimeters incision. We go inside. The lens is covered by a capsule. So we make a circular opening in the capsule of the lens, the outer covering of the lens. This is called a capsulorhexis. And we need a very round and regular capsulorhexis. After that, we go in with our phaco probe. So this is an ultrasonic probe. It vibrates. And then this ultrasonic probe helps to emulsify the pieces of the nucleus and remove it. This is the loose cortical matter that is being removed, and now you see we have a clear capsule with that circular opening in front. And it is in this bag, this capsular bag, that the artificial intraocular lens is implanted. So this is a foldable lens. It goes in through that very small 2.2 incision and fits nicely in the bag of the lens. So this is how cataract surgery is done today. These incisions are self-sealing, very small incisions, so you don't have to suture them. So what has actually changed in cataract surgery is that from very large incisions, we've moved to micro-incision surgery, where the incision can be as small as 1.8 millimeter. Earlier, we were doing surgeries under block, that is, we would give an injection to anesthetize the eye. But now most of the surgeries are done under topical anesthesia, where just anesthetic drops are put. And it's become a daycare surgery, so it's a walk-in, walk-out surgery. The surgery itself takes around 15 to 20 minutes. So this is just to show you the differences. This was the extracapsular surgery, which was done in the days of yore, where the entire lens was extracted through a large incision, which then had to be sutured. But today, we do it through a very small incision. So this incision gives us the advantage that it's a self-sealing incision. It heals faster. The patient can be rehabilitated very quickly. We don't even have to put a bandage on the eye. And most importantly, it doesn't induce any astigmatism. That is a cylindrical number after the surgery. So like I mentioned before, earlier we would give a block, that is an injection in the inferior part of the eyeball to anesthetize the eye and to prevent it from moving. But now most of our surgeries are done under topical anesthesia, where we put eye drops. The patient is instructed to look at the light of the microscope and most of the times the patients do cooperate. It's only in the one-off uncooperative patients or patient who's mentally challenged, cannot follow instructions, is hard of hearing, or the cataract is very complicated, hard cataract, that we now need to give the block. Otherwise, just the topical drops. So like I mentioned, the recovery is extremely quick. The eye is generally not bandaged. The only instruction that we give to the patient is that no rubbing of the eye or getting water into the eye for around 1 week after surgery. The patient is allowed to shower or bathe 24 hours after surgery itself with the eyes closed. And there is no restriction of any sort whatsoever on any activity. So watching TV, going out in the sun, lying in any position, eating hard food. So these are some of the misconceptions that patients have. Ki hum, hard cheezein kha sakte hain. Can we go out in the sunlight? Can we watch our TV or phone? So everything is allowed. But eye drops, that is antibiotic steroid eye drops and lubricating eye drops, have to be instilled for 6 weeks till after surgery. Now, another very remarkable development in cataract surgery has been that cataract surgery is no longer now done only to improve the vision of the patient. It has also now become a refractive surgery where we can help the patient get rid of his glasses. So any patient who had a pre-existing refractive error, where a hypermetropia or myopia, once he does the cataract surgery, we can put that same power in the lens that is implanted, so the patient can get rid of his glasses. Another thing that has changed is the transition from monofocal to multifocal and now extended depth of focus lenses. So earlier, we would just implant monofocal lenses. Monofocal lenses means that the patient would be able to see for distance, but for near, he would have to wear reading glasses. So over the years, there have been a lot of developments in the lenses, and there were multifocal lenses which came up, which would give the patient near vision even without wearing glasses. But these lenses had their own set of problems. They would give a lot of glare and halos. So now we have the newer generation EDOF lenses, which are relatively free of these problems like halos and glares while driving. So this is the presbyopic correction. The artificial lens would not be able to focus for near, but when we put these new advanced lenses, the patient would be totally spectacle free. Also, in patients who have a cylindrical number, that is astigmatism, we can put a special lens called a toric lens. So if the astigmatism is more than 1 diopter, we can also correct the distance number for the distance cylindrical number. So the patient would now have complete independence from glasses. So this was a very high myope patient who had worn glasses all her life. She had a number of -10. She was never able to see without, first thing she had to do in the morning was reach out for her glasses. After cataract surgery, now she can see for distance and near without glasses. So she's become totally spectacle free and a very happy patient. So this is what we are now offering the patient, complete independence from glasses apart from clear vision. So now there are a plethora of new lenses. There are new lenses coming up every day. So like I mentioned, toric lenses are done to correct the cylindrical power if the patient has a pre-existing cylindrical power. Multifocal lenses have now gone out of favor because they would cause a lot of problems while driving at night. So they had rings on them. So if you see that lens, it had rings on it, and these rings would scatter the light. They would give you good near vision. Patients would be able to read even the newspaper without glasses, but they would scatter the light and cause halos. But now these EDOF lenses, that is extended depth of focus lenses, have done away with these problems. So my favorite lens now is the Pure C IOL. So this lens doesn't have any rings. I've implanted more than now 50 lenses. None of the patients has come back with any halo, any glare, any problems in driving. And patients have excellent distance vision, that is 6x6, and their near vision is adequate for them to work on their phone, see their WhatsApp, see the YouTube. For reading the fine print of the newspaper, they may still require to wear glasses if they have to do prolonged reading. But most of their work, they would be glass free, both for distance and for near. So a patient who was earlier wearing glasses for reading, like I am wearing glasses, if he underwent cataract surgery, he would be able to get rid of glasses even for reading. But the prerequisites before implanting these IOLs is to do a precise IOL power calculation. That is extremely important, and we need the new generation machines to give us a precise calculation of the power of the lens that we have to implant. So this is a biometer which calculates the power of the lens. The patient sits on it, the machine itself calculates the power. These are the charts that we get, and we can titrate the power of the lens what we want for the patient seeing this chart. Another prerequisite before implanting these are called premium IOLs. You know, they are more expensive than the regular monofocal IOLs, of course, almost double or triple the cost of the monofocal IOLs. But before implanting these premium IOLs, a thorough retina evaluation is extremely mandatory. So this is how a normal retina looks like, and that is the OCT. So an OCT test is done before every cataract surgery to see if the retina is normal or not. So that is the normal contour of the retina. In this picture below, you can see there is a membrane on the retina that's called an epiretinal membrane. So in patients like these who do not have a normal looking retina, these premium lenses would not work. In fact, they would cause them more problems. Again, this patient has a macular edema, a diabetic patient with swelling of the retina. So in these patients, these premium lenses will not work. So it's extremely important that we do a thorough retina checkup and do an OCT for all these patients before suggesting these expensive IOLs to them. So just a few practical points for everyone. When to advise cataract surgery? So symptoms matter more than visual acuity of the patient. So nowadays there will be that one patient who would have 6/6 vision but would be having a central cataract which would be causing him a lot of glare while driving, or if he has to do very precise work, his vision would be good but the colors would appear faded. So it is the symptoms of the patients that matter more than the visual acuity. So patients who have glare, halos, difficulty in night driving, fatigue while reading, these are the patients who can go in for early surgery. Even when the cataract is at a very early stage, if they have symptoms, then we advise them surgery. Now, it's always better to do surgery earlier than late. So the earlier concept which most of the patients still have is कि हमारा cataract अभी पक्का नहीं है. Paka means it has turned white like this. Now, to do surgery on such a advanced cataract becomes more challenging for the surgeon because the surgery becomes more prolonged. Like I showed you, we have to break the lens into pieces. So since it's so hard, the surgery time goes up, the comfort of the patient goes down. So we advise the surgery to be done earlier in the course of the cataract rather than late. So don't wait for the cataract to mature. Systemic conditions, diabetic control is extremely important. Retina evaluation in all diabetic patients especially is mandatory because if the patient has a pre-existing diabetic macular edema, it can worsen after the surgery. Hypertension should be under control. Anticoagulants and antiplatelets are generally not stopped. And on patients who are on dialysis, this has to be done a day before. So femtolaser, just one slide more. Femtolaser is another new development where the incisions and the opening in the lens and the lens is broken into pieces by laser itself. So manual intervention is much less, and the advantage, it does offer advantage in a certain subset of patients, especially with hard cataracts. The future is robotic surgery. A lot of robots are being developed, and the extreme future would be eye drops, which would prevent the cataract or dissolve the cataract from happening. So just a short overview of cataract surgery as it stands today.
Thank you, Dr. Tinku Bali, for excellent coverage and synopsis of the cataract surgery is still in the process of evolution. I think we might see much more in coming years. And as she rightly pointed out, that laser, there's a misconception in general public that cataract surgery is being done by laser. It is a laser assisted. The basic suggested by the ultrasonic phacoemulsification. Lens size is same, cut size is same. So there is one thing. Second, the premium lenses or no premium lenses must get an OCT done of your patient because patient asks you for final vision after surgery. And I have a small reservation about the EDOF lenses. I still have some reservations. So if you go for a premium lenses, understand it fully, discuss with the doctor fully. I also, pure C only, I have seen a patient she's very troubled. So not that most of the people are using it, a lot of patients are comfortable, but you must understand what you're going for. Monofocal toric, of course, toric is one that we'll always advise. Premium lenses, discuss, then go for it. I'm only allowed 2 questions for Dr. Tinku Bali from the program controller, so we can take only 2 questions.
There are no questions.
No questions?
Purely,
Sorry, I thought I had to put up a question. Okay.
for purely refractive reasons, with a very high numbers, would you advise a cataract surgery?
So there are there are patients with a very high number who are not suitable for LASIK procedures, or patients who are, in the 40 to 50 age group who have a number and want to get rid of it. So we do something called a clear lens extraction. So it is, the lens is clear, it doesn't have cataract, but you do the entire surgery as you would a cataract surgery and implant the lens. So yes, it is done for removal of glasses, a clear lens extraction.
I would like to add to that.
Refractive lens exchange.
I would like to add, these days we are getting a full segment of patients. They have no cataract, including my wife. She has put me this question since the last 1 year. She's not happy with her glasses for near vision. She has no cataract, and these are the quality of patients that are coming to us, 45-year-old, 50-year-old, 55-year-old. She says, I don't want to wear glasses, so what to do? So this is partly the answer of your question. She doesn't have any distance vision problem. She's 6/6, but near vision is disturbing her. So these days, there is a new set of surgeons there. They call themselves the RELEX surgeons, refractive lens exchange. They are claiming to be RELEX, RELEX surgeons. And this is new in the market. So this is what is happening. They are offering these premium lenses, but again, like Dr. Jha said, premium lenses are not the perfect lenses. Pros and cons are there. You discuss with the patient first. If the problem of reading is more than the problem that she will get after getting the lenses, like glare or any other problem, then you can go ahead. But patient has to be explained thoroughly, told about that these problems can crop up. You might be able to read better after the surgery, but nighttime driving may become difficult. If you are a driver driving in the nighttime, there can be glare and that can cause problems. So these things have to be clearly told to the patient, and they should understand. We should get it signed on the paper and only then go ahead.
So even this glare and halos with the newer lenses, I think, has gone down tremendously.
No, it has gone down, but still they are
there. There would be one-off patient, and also there's something called neuroadaptation. Maybe for the first 1 or 2 months, the patient would have some glare, but then after 2-3 months,
after 6 months, they do adapt.
Generally settles down. It doesn't cause much problem.
Are the redos possible in these patients at any stage in life? And the second question, normally we do cataract at the age of say 60, so they have 20 more years left, give or take. But if somebody is 40-year-old at the age of 80, what complications do you see in such a long lifespan of the cataract surgery?
So the lens that is implanted is for life. We do cataract surgery in newborn babies also, in young children who are born with congenital cataracts. So once the cataract is implanted, it becomes a part of your body and it's there for life. Yeah, doesn't really matter.
I think the last question, Dr. Bali, you answered. I think we'll have to close this session after this. Answer this question.
Indian versus imported.
So I think the quality of vision is better. The Indian lenses are also doing very fine. But the quality of vision may be very minor factors like contrast sensitivity, color, saturation. These are the factors that are better. These multifocal lenses, our Indian companies still have not been able to come up with multifocal lenses that are up to the mark and, in competition with these imported multifocals. But for monofocal lenses, yes, the Indian lenses are equally good.
So if you want to go for a good budget lens, then Indian lenses are fairly good. So
for monofocals.
I think the main difference is the price factor only. Indian lenses are now competing very well with these imported lenses. May not be the same, but they are definitely very good lenses.
Thank you to all the chairpersons for the last 3 sessions. As we move on, I have 2 important announcements. For all the speakers and chairpersons, please collect your certificates from the front desk. And for each session, we'll be taking 2 questions per session. And in case there are more questions, you can ask the speakers during the lunch. As we move on, our next session is on cervical cancer and HPV vaccine. It is by Dr. Huma, who's an associate consultant, and I would like to invite Dr. Mala and Dr. Chandra onto the stage to be the chairperson. Dr. Huma will discuss HPV vaccine as a key preventive strategy, addressing common myths and practical counseling points for physicians. I would also ask the speakers to be mindful of the time. So we have two buzzers, one which ends when your session ends at the end of 10 minutes, and the other after the question time ends.
So good morning, everyone. Today we are going to discuss about the HPV vaccination, which is actually the need of the hour, a very common practice, something which is upcoming and needed in our country. So let's begin with the session. So what is HPV? HPV is human papilloma virus. It is a group of virus which contains around 200 varieties. They do not cause concern in most people, but in some high-risk varieties can lead to genital wart as well as cancers. Approximately 90% of the individuals who are infected with HPV virus, their own immunity clears off the infection by itself. However, if this infection persists, it can lead to number of cancers like vulva, vagina, cervical cancer, mouth cancer, penile cancer, and anal cancers. So prophylactic vaccination against HPV can prevent these cancers. So why we need to discuss this? Because we all know India is the second, India contains around 20% of the global cases of cervical cancer. And it is in India, cervical cancer is the second most leading cause of cancer death in women aged between 15 to 45 years. So HPV, it is not just cervical cancer. It can lead, it is a major contributor for many of the cancers. In oropharyngeal cancer, it is there in 13 to 56% of the cases. In anal cancer, 88% are infected by HPV. In penile cancer, 50% individual. Cervical cancer, almost 99% are infected by HPV virus, whereas 70% and 43% of vaginal and vulval cancer are attributed by HPV virus. So we know there are more than 200 varieties, but there are 40 subtypes which infect the mucosal epithelium, and it can cause various cancer. So when we are concerned about the cervical cancer, the high-risk varieties mainly is 16 and 18, which contributes to around 70% of the cervical cancer. The other high-risk varieties are 31, 33, 45, 52, 58, and 68. And the low-risk varieties are 6 and 11. They do not cause cancer, but they do cause genital warts. So in which population cervical HPV is more common? Women who are living with HIV infection, homosexual men, immunocompromised individual, people who are co-infected with other STIs, women on immunosuppressive medications, and children who have been through sexual abuse. Even in men, the prevalence is around 26.7% in India. And if you see the spouses of or the partner of the cervical cancer patient, around 66.7% males are infected by HPV virus. So we know we have two vaccines which is commonly available in India, the quadrivalent as well as the nonavalent. The quadrivalent contains the high-risk virus like 6, 11, 16, and 18, and the nonavalent contains, other than these four, 31, 33, 45, 52, and 58. So the best way to prevent HPV infection, cervical cancer, and other HPV-related cancer is early vaccination. So history of HPV vaccine, it all started from 2008, where bivalent and quadrivalent vaccines were licensed in India. Now we have our own indigenous vaccine known as Saurabh, which was launched in 2022 by Serum Institute of India. So what are these vaccines? They are produced by the recombinant DNA technique via cell culture technology. They do not contain the live virus, but they have a virus-like particle, which is prepared from the alveolar structural protein of the virus cells. And it is administered by the IM injection. So what do we have? We have Gardasil, which is a quadrivalent, contains 6, 11, 16, 18. A nonavalent, which contains 6, 11, 16, 18, as well as 31, 33, 45, 52, and 58. And Saurabh is also a quadrivalent vaccine, 6, 11, 16, and 18, which is more affordable. So coming to the guidelines, they say for the optimal dose for 9 to 14-year-old female is 2 doses, which is at least 6 months apart. 15 to 26-year-old individual, there are 3 doses at 1 to 2 months apart and 6 months apart. 3 doses for older women up to 45 years of age. But in these older women, we need to concomitant screen them also for HPV virus by LBC or the pap smear. Now coming to the upcoming thing, which is the reduced dose guideline. They say only 2 doses, 1 or 2 doses can be given for the 9 to 14 years. 1 or 2 doses can be given for 15 to 20 years. And 2 doses are mandatory for 21-year age and above. For boys, they say we can vaccinate the boys from 9 to 26 year of age, 9 to 14 years, same 2 doses, and 15 to 26, 3 doses. So why do we need to vaccinate them early? Because earlier they are earlier they are vaccinated before they acquire the infection. Their immunogenicity is higher, and there is 2 times higher protection of the cervical cancer as compared to older individuals. And why do we say then we should vaccinate everybody up to 26? Why do we need to vaccinate the elder women? Because at least we can offer them a catch-up campaign. Risk of new exposure, clinical studies can be decreased. Clinical studies have demonstrated that the efficacy of the vaccine in helping to reduce the cervical cancer diseases in 24 to 45 years too. Now, coming to special scenarios in which HPV vaccination can be offered. HPV vaccination can be offered to lactating women. All the guidelines say it is pretty safe, and after in the lactating woman, it doesn't affect the breast milk or the cross immunity of the kid. Male vaccination, why it is important? Because if males are also vaccinated, the chances of cervical cancer in their partner decreases. Can vaccine be given with another during pregnancy? No, it is not recommended that pregnancy should be the time where we should vaccinate with HPV vaccine. However, all the guidelines say that if the woman is undergoing vaccination and then she is conceived, do not terminate the pregnancy. The pregnancy can go and proceed, but the pending and the reminder doses can be given after the delivery of the patient when she is lactating. Do not vaccinate her during the pregnancy. And if the individual is coming to you who is not vaccinated, it's a very good time to counsel them for the HPV vaccination after her delivery. So another scenario that can arise is, can one vaccine be interchanged with other? Ideally, we should not mix the vaccine, but yes, if the first vaccine that she has got and it is not available currently, you can vaccinate her by other medication, but the preferred thing is whatever dose she has got before, whatever vaccine she has got before, she should get the remaining doses with the same vaccine. So should we all do HPV test before giving the HPV vaccine? Another thing which might come to your mind is that it is not necessary to do HPV screening before administering the HPV vaccine. However, if the individual falls into the criteria and age criteria of the LBC testing and HPV testing, she should undergo HPV testing and LBC testing as for age appropriate guideline, irrespective of her HPV vaccination status. And even the women who are vaccinated by HPV, when they reach their age appropriate for screening, please do screen them. It is not an alternative for the screening. It is just for the immunogenicity and protection. However, the routine screening for LBC or the pap smear or HPV testing should be there for all the women, irrespective of their vaccination status. So what happens if a patient misses a dose of vaccine? Foxy says whatever remaining doses are there, we can give it later on too, irrespective of when she has got her first dose. Ideally, she should receive the vaccine within the timeline. If she has not received, she has missed it, whenever she comes to you, do administer her pending doses. So can it be given with other vaccine? That is another thing. So yes, it can be co-administered with other vaccine, but in a separate needle and a different anatomical site. Who should get HPV vaccine? Who should not get HPV vaccine? Life-threatening allergic reaction to any ingredients of an HPV vaccine, an allergy to yeast, pregnant woman, and moderate to severe illness. We should avoid giving HPV vaccine to them. Now coming to special situation, in HIV positive or immunocompromised girl, it is always a mandate that 3 doses should be given to them irrespective of their age. In case of interrupted doses, continue with the remaining doses as per the age-based recommendation. Vaccine series need not be restarted. Vaccination of pregnant women is not recommended. Pregnancy testing is not necessary before vaccination. Inadvertent vaccination during pregnancy is not an indication for pregnancy termination. If pregnancy occurs during the first dose of vaccination, the subsequent doses if applicable, should be delayed until after pregnancy resolution or after delivery. It can be given during lactation. So with this, I end my lecture. Thank you all.
Thank you, Dr. Huma. It was really very crisp.
Sorry, ma'am? No, ma'am. If we are giving the 2-dose regimen, it is 0 and 6 months. 6 months apart. Since 6 months apart. If
Dr.
the 3
Huma,
doses are there,
yeah, she clearly described what is a HPV infection, and this is a cause of at least 6 malignancies. So these all are preventable. So what is the magic of the HPV vaccination? You see, you give one vaccine, 2 doses, and you can prevent the 6 malignancies. So rest malignancies in the women, the ovarian, uterine, we cannot prevent. There are high-risk factors. We can avoid those high-risk factors, but there is no vaccination for the ovarian cancer. But there is a vaccination for the cervical cancer, vaginal cancer, and vulval cancer. So I think this is a very, very important, this message should go to everyone. Whatever the women, the young girl coming to you, you should advise them this HPV vaccination. So in young girl, only the 2 doses are required. And after the 26 or after the 14 years, you need 3 doses. But it should be given to each and every girl. Dr. Mala.
I have 2 questions.
Yes.
I'm Dr. I wanted to know one thing in the reduced regimen. Are we following 06 or 02?
ma'am, 06. 06.
Second thing, if someone above the cutoff age, like a boy above 25 or a lady above 45, asks me for a vaccination, can I give the vaccination with the written consent?
See, it is not recommended.
It is not recommended.
So,
yet.
if it is not recommended, but you can discuss with them, and if they are giving consent, you can give them, but you are not saved by the court of law. But that is individualized. You have to individualize.
That is their decision. It is
Their
not
decision.
recommended because we need to vaccinate the population which is more vulnerable rather than vaccinating a 45-year-old. In our country, if you see the girls, they are not vaccinated. They are our prime target. They are our focus population.
Primary target.
So we should focus on them more than
Rather
a 45, 48-year-old lady.
No, mothers should be encouraged for screening.
Yeah,
Screening
because
of cervical cancer, and their children should be vaccinated.
Vaccinated.
Another very important question. Excuse me, ma'am.
Yes.
In the era of preventive health checks or preventive HPV, the question is the level of evidence for boys is 2C.
Yes.
Yes. See, and things are very expensive. Vaccines are very expensive.
Yes.
And then the patients feel you're.
Sorry to Dr. Saab, it's not expensive. We should not say it is expensive. The treatment of the malignancy is more expensive.
Gangaram are not India.
Yes.
So, Bobby, even the rich person right now.
Indian vaccination, Saurabh is available. That is cheaper, quite cheap.
With a 2C recommendation, because the drug companies are a billion-dollar industry who are pushing everything for everybody.
See, basically,
it is
our primary target is.
Yes, sir.
We really push for boys.
So our first and foremost target is the young girl.
Girls.
Because we need to vaccinate 90% of the young girl by 2030. That is the WHO recommendation. Yes. So
for boys,
पहले लड़कियों की तो
there is a
डिमांड पूरी हो जाए
chance
तब
of
हम
herd
लड़कों पे आएंगे
immunity.
ना. That is the fact.
See, one dose, at least they will get
At
the
least
benefit of 1 dose, and
At
it
least
gives
1 dose.
herd immunity. That there will be benefit of herd immunity. That was the idea of WHO. See, we have to understand that every 8 minutes, 1 woman is dying of cervical cancer. That is the burden of cervical cancer in India. And WHO is saying 90, 70, 90. That 90% of the girls between the age of 9 to 14 should be vaccinated. Our primary target are girls 9 to 14 years. 70% of the women should be screened and 90% of the treatment should be there. The goal is to get elimination of cervical cancer by 2030, and we are trying to reach to that goal. That is what we are all aiming at.
Even in Gangaram, we have organized almost 4 camps for HPV vaccination, and the turn-up had been very good because people are getting aware by newspaper, everything.
See, in these camps, we have arranged for 1,300. Sarvavac for 1,300. And we are giving it to them.
One dose.
For one dose. 1,300 for one dose. And almost every 2 months, we are having this camp in Gangaram Hospital. Thank you.
Thank you all.
Thank you. And now we move on to an interesting session by Dr. Raman Kapur. Sir is the head of Department for Medical Acupuncture, and he's going to talk about the need of acupuncture training amongst Indian doctors. This facility which we provide at Gangaram Hospital is also well recognized by the Government of India, and Sir himself is a Padma Shri awardee. To chair this session, I would like to request Dr. Lalit Duggal and Dr. Neeraj Jain to join us.
Thank you and welcome to this very important session. Why I say that is because it's a very unrecognized and a topic or a field which many of us don't give importance to. I'm talking to you from a rheumatologist point of view. 25% of our patients of fibromyalgia elsewhere just go around with pain and are helpless. So we actually depend on Dr. Saab here for help. Over to you, Dr. Raman.
Thank you, sir, for the introduction. Most importantly, a very good morning to all of you. It's so good that Sir Gangaram Hospital is one of the leading institutions in our country, which recognizes the importance of holistic healthcare. And I joined this institution about 29 years ago, and I am into active medical acupuncture since the last 44 years. So, the need for acupuncture training amongst Indian doctors to enhance clinical outcomes. Now, why is this question coming up? The reason is, why discuss acupuncture now? It is because the rising burden of chronic pains, as Dr. Saab is rightly saying, lifestyle disorders, stress-related disorders, and the limitation of pharmacological managements because of the side effects of drugs, the long-term dependency on drugs, and the cost burden. And acupuncture here comes up as a safe, cost-effective, evidence-supported therapy. It is a bridge between symptom relief and functional recovery, and there is a global acceptance today of integrative medicine. Let me tell you, the next 50 years of our lives will be integrative medical care. It will not be one system care. It will change over totally to an integrative health care, and that is where acupuncture comes at the top. Because WHO survey done recently, and this is a document which is released, WHO 2023 to 2034, says that the system of medicine accepted globally today after Western medicine is acupuncture. Even it was a surprise to me. It was not Ayurveda, it was not homeopathy, it was not yoga, it was acupuncture, which means the acceptability of the system has grown very, very fast over the last 2 decades. Now, what does evidence show? So, evidence-based role of acupuncture in hospital practice. This, particularly I'm talking about the systemic reviews and meta-analysis, and we are only talking about the PubMed evidence which is available today. It shows that in pain management, particularly in cervical and lumbar spondylitis, osteoarthritis of the knees, sciatica, post-operative pain and frozen shoulder, very good results. Neurological and rehab care, wherein stroke rehab, particularly the motor recovery and spasticity, Bell's palsy, peripheral neuropathy. Then in internal medicine and lifestyle disorders like migraines and tension headaches, IBS and constipation, insomnia, anxiety, menstrual disorders, and today infertility is the catch-up point. So all teams of which treat infertility globally today, particularly in the US, Australia, and UK, they have to have a medical acupuncturist as a part of the team. that important it is now to have giving acupuncture to patients who are getting treatment done for infertility, particularly for failed IVF and IUIs. We have done a lot of cases in Delhi, and we are very proud to say that many of these patients who have had failed IVF and IUIs recurrently have been able to conceive naturally with acupuncture. Then chemotherapy-related nausea and perioperative pain, acupuncture is again very useful. Then the clinical advantage is that it reduces the use of analgesics. There is faster rehab, and there is improved patient satisfaction. Then acupuncture as an integrative tool in Indian healthcare. It will complement Western medicine, orthopedics, neurology, physiotherapy, and psychiatry. And it works very well in OPD pain clinics, in rehab wards, in post-surgical recovery. It supports the vision of integrative medicine. And the important message for doctors is acupuncture does not replace modern medicine. It enhances the outcomes. Then the safety, ethics, and hospital protocols. It is essential for credibility in a hospital setup. So you use what we use also in our practice for the last many years, pre-sterilized single disposable needles. There has to be proper documentation and consent of the patient. There is a clear referral and co-management with physicians. There is awareness of contraindication, like in pregnancy, there are specific acupuncture points which should not be needled. Bleeding disorders, in pacemakers, patients who have pacemakers, we should avoid doing electroacupuncture. So competent acupuncture is what is known as safe acupuncture. Then training and skill development for acupuncturists. So the stress is for the need for continuous medical education, which we are doing for the doctors who we train in India. There is clinical audits and outcome tracking, case-based learning, and an interdisciplinary communication. So we are also having a training model in India now. It is as per WHO guidelines, as per the ICMR has cleared those guidelines. So the last 15 years or more, since the guidelines have been established and published by the ICMR, it is exactly for the medical doctors. This course contains about 1,400 hours of online theoretical component and about 240 hours of hands-on practice. So the entire course is given over a period of 1 year with 4 modules of hands-on training of 10 days each. So 40 days of hands-on training in a year, and each session is about 6 hours. So it covers about 240 hours of hands-on training, which is enough for a medical doctor to start practicing acupuncture in his own practice. There is now the government of India has accepted acupuncture as an independent system of healthcare after a lot of efforts by me over the last 2 decades or more. And now we are going to start diploma and degree courses in acupuncture after class 12 under the NCAHP. But the most important thing which I must share with you is that the number of MDs practicing acupuncture in India, the qualified doctors, is quite less as compared to what I have seen internationally. So there are 2 types of people who are going to be the backbone of acupuncture progress in India. One would be the MDs, or the qualified medical doctors, who start learning acupuncture more and more and enhance their clinical outcomes. And the second would be the LACs, or the licensed acupuncturists, who do such courses after class 12. This is the norm internationally, and this is the way they have been able to develop the system there. So this is very important to understand. So the key takeaway is we should advance patient care through acupuncture competency, which means delivering safe, evidence-based, integrative and compassionate healthcare, which is aligned with India's evolving medical ecosystem. I would like to share, with the permission of these patients, 3 case snapshots. The first case snapshot is of Dr. Kiran Bedi, whom all of you must be knowing very well. She is the ex-Lieutenant Governor of Pondicherry. She came to me in 2015 when she was campaigning in Delhi for her elections, and because of the recurrent rallies and speaking loudly, she had totally lost her voice. And she had an acute laryngitis. The vocal cords were swollen. Dr. Sama was the first gentleman who saw her, And after giving courses of antibiotics and steroids with no change happening, he asked me to come in. Being a medical doctor myself and practicing acupuncture, we gave her once a treatment session only, and in 1 hour session, the next day her voice was back and she could go back to her election rallies. Since that time, this lady has totally evolved into a promoter of acupuncture, because for any short problem of hers, like she had a frozen shoulder, she came to me for acupuncture and she responded in 4 to 6 weeks. For low immunity problems, which she tends to have, recently had developed, and she was getting recurrent viral infections, she came to us and she again recovered. So this is one very interesting case snapshot. Another case snapshot is of the ex-Chief Justice of Supreme Court of India, Justice G.Y. Chandrachud, who retired last year. And look, even a man of his level was not aware about acupuncture. So it was only a coincidence that Mr. Sundaresh Menon, who is also the Chief Justice of the Supreme Court of Singapore, was visiting New Delhi at his invitation. And he found this gentleman very restless in his chair. And he asked him, what is the reason? So he told him that, I have had this back problem for 7 years, but I have never got it resolved, because every time I take a few painkillers, maybe physiotherapy, it gets better, but then it comes back after every 6 months. So he says, look, I had a similar problem, and I took acupuncture back in Singapore from a medical doctor, and since the last 10 years, it's never come back. So this is the way he came to me, and he has also had great results, and now he's on a follow-up treatment with me. I just call him once in 6 to 8 weeks, and that's it. And the last case is of Mr. Chuck Muncy, who was the ex-ambassador of Singapore to India. He had a surgery of his knee, and after the surgery, he recovered endoscopic surgery in 1999. But since then, he couldn't play golf. So he was, because of the lack of strength in the knee, that he couldn't play golf. So he came to me for help, and I gave him sessions for about 2 weeks, and after that, the pain was gone. And surprisingly enough, for him, his surprise, he found his knee had regained strength, and he could start playing golf again. Similarly, he had hay fever problems. We fixed up the hay fever problem, allergic rhinitis, with acupuncture. And the last problem which he came to me was for his cervical problem. We used to have a very acute stiff neck because he had 3 cervical vertebrae removed by a surgery, and subsequent to that, his neck was always stiff. He couldn't move like this. And with just acupuncture treatment for about 5 to 6 weeks, his neck pain was gone and his stiffness was gone. So thank you very much for your patient hearing, and I am quite confident that many of you would be interested in learning this art. My wife, Dr. Sunita, who also works with me, has been into the teaching of acupuncture for the last over 2 decades, and we've already trained about 500 doctors in this country, all over the country. And we are very proud to say that we continue to teach, and we really feel that more and more medical doctors should take up this as an add-on technique to their own profession to give better results for their patients. Thank you.
Thank you, Dr. Raman. I think in the interest of time, we'll just take maximum 2 questions.
Any area where it doesn't work?
Broken bones and broken hearts.
Just one more question, please.
Sir, what is the therapeutic basis of the acupuncture? What are the modes of action?
Yeah, the mode of action is it works through the neurovascular bundles. So you see, earlier on, when traditionally acupuncture was developed, it used to be talking about meridians and channels. But now with Western medicine knowledge coming in, and with a lot of research happening, now it is all confirmed that it is all happening through the brain. So it's all biochemical in nature. Like, for example, for pain relief, we have confirmed that there is release of endorphins and enkephalins from the brain, which give pain relief. Similarly, for immunity enhancing, we have found that there are certain acupuncture points at which, when points are needled, the lymphocyte neutrophil ratio can get better with acupuncture. Yes, very correct.
I think we'll close the session, and maybe we can have some discussion over lunch.
Thank you very much. Thank you, sir.
And I would just like to add, I'm also your patient, and I'm almost 100% better. I had a bad radiculopathy.
Yes.
And you, in the COVID time, you helped me out.
Yes,
Thank you so much.
Thank you very much, sir. Thanks.
Very important question. Yes, I would like to. With due respect and regard, sir, how do you fit your evidence-based practice in modern science? We are not taught of, and we do not have till-date research or correlation or scientific-based evidence in our modern medicine. How do you explain, sir?
Sir, it is all available now. Now those days are gone. That's what I'm trying to tell you. Now go to the Google, check on WHO websites. You will get PubMed studies which have proven beyond doubt that it is scientific in nature, and there are plenty of studies available which show that acupuncture is a proven science.
Why we are not taught of?
Sir, why we are not taught? This is something which you are very correct in saying. But then, as I said to you, the pharma lobby is too strong everywhere globally. We all understand it, and I am a part of that, because I also came from the Western system only. But try and understand any alternate system today. It takes a lot of effort to popularize it, to make it pick up. So this is the major reason why it is not picked up that much as you and I would have wanted it.
Thank you, Dr. Raman. I think we can't discuss these things because we are not taught homeopathy. We are not taught, we are allopats. We are allopats. Yeah, we are. Okay. Thank you.
Thank you, sir. Thank you very much, sir.
Thank you.
Thank you very much.
Thank you, sir, for such an enlightening session. It was definitely something we all did not know much about. I would like to remind the audience that we are having two questions per session. In case there are more questions, you can always contact the speakers during lunch hours. We have to be a little mindful of our time. For the next session, we have Dr. Saurabh Taneja, Senior Consultant in Critical Care, who's going to talk about medical emergencies and where early recognition can save lives. He'll focus on early warning signs, timely referral, and initial management strategies which are relevant to primary care physicians. I welcome you, sir.
Welcome, Dr. Saurabh, our intensivist in the hospital and one of the most important and I think critical component as far as management in hospital is concerned. Over to you.
At the onset, I would like to thank the chairpersons for the kind introduction and Sir Gangaram Hospital for making me what I am, and to all of you for coming here and trusting the hospital. Yeah. So I'll be talking about sepsis. I don't know, my first slide is not there, but it's okay. I'll be talking about sepsis, early recognition and management. So the idea is why is sepsis so important in nowadays life? So worldwide it has seen that lot of expensive medications have been developed, the antibiotics, and lot of lives have been lost. So it has got a financial mortality and morbidity worldwide. So the burden is too much and we should discuss it. So the idea is to have people catching sepsis early. So that is why I've chosen this topic, especially for the people who are seeing the patients for the first time, you all, that how do you recognize sepsis early and how do we manage that in the hospital settings. So firstly, we should need to differentiate between what is sepsis and what is infection. And then we're talking about early diagnosis management, some newer developments, and a take-home message. So why early recognition matters? So because in various studies, it has been proven that every hour of delay in administering antibiotics to a sepsis patient will lead to mortality. And any delay in fluid resuscitation will lead to organ failure. And the source controls, if delayed, will lead to a prolonged admission for a septic patient. So it is very important that you catch sepsis early and you rationally treat it. Now, primarily sepsis was thought to be just infection, but it is not infection. We need to differentiate that sepsis is infection plus life-threatening organ dysfunction. So we need to catch this organ dysfunction very early. We all have so many infections, but not in all infections go on to become sepsis. The idea is to catch the organ dysfunction very early. So when I talk about organ dysfunctions, it can present as various organs like hypotension. The BP can be less than 100 or the mean can be less than 65. The patient can present in altered mental status, a reduced urine output, history of 8 to 12 hours. Patient, if you measure the saturation, it is less than 90 to 90%, and there is skin mottling or delayed capillary refill. So these all tend to present as organ failures. So we have to take that into account. Any patient who has infection in which we are treating them as an infection with some antibiotics and the patients develop these signs and symptoms, we need to refer them a bit earlier and we need to escalate the care of these patients. So the subset of high-risk patients in which we need to act more aggressively are the elderly patients, the pregnant patients, the immunocompromised set of patients, and the patients with uncontrolled diabetes, liver disease, or kidney disease. Because the sepsis is very fulminant in these patients, it can develop very quickly. So the idea is spot the sick patient early, check the vitals, trigger escalation. So in all our clinics, in all our first visit to patient interaction, we can check these things at least: the saturation, the respiratory rate, the blood pressure, the heart rate. We can take a history, we can talk to the patient, assess their mental status, and take a history of urine output. This can be done by all of us at all the times. And why are these important? So we know fever is very important, but hypothermia is also very dangerous. So any patient who tells you that I am having hypothermia or my temperature is less than 36, you should take it very seriously. And especially in immunocompromised patients, elderly patients, any kind of infection usually does not have fever. So in these patients, we should not try to illustrate a history of fever, but look at the other signs and symptoms. Now, tachycardia, all the patients who are having fever or hypovolemia, they can present as tachycardia. But early shock with decreased blood pressure or a patient going into an early cytokine storm response will also present as a tachycardia. Tachycardia, especially more than 120, should make it suspicious for us. Similarly, for tachypnea, although any fever patient can have tachypnea, but fever along with hypoxia, if it is there, then there is chances of lung infection being developed. So we have to keep that into mind as well. And we should diligently measure the respiratory rate, a practice which is now lost somewhat. Now, blood pressure, there are many blood pressure criteria there, but early hypotension in a patient of sepsis can tell you about vasodilation and septic shock. So keep that in mind when you measure the BP. If it is low, and if you check it at two occasions, probably 1 hour or half an hour apart, that means we have to escalate the treatment of this patient. Especially in elderly's sepsis, or it presents as septic encephalopathy, new onset confusion, drowsiness, or a patient getting agitated. These are typical signs of sepsis which presents especially in elderly patients. Now, the patient going into septic shock, we should look at the blood pressure, any new onset confusion, decreased urine output. So any decreased perfusion to any part of the brain or any part of the organ system in the body will present as signs of poor perfusion and shock. Even skin mottling, which is measured around the knees, can tell you that the patient is having signs of poor perfusion to the skin. Now, we all do organ-specific examination, so I'm not going into detail, but whatever source of organ you feel that the patient is having sepsis from, or the sepsis or infection is originating, should in detail examine that organ system. So I'll be talking a bit about the lab investigations and biomarkers, which are nowadays very prevalent. So we all used to do complete blood count, but leukopenia is as equal marker of sepsis as leukocytosis, even thrombocytopenia or leftward shift or toxic granulations in the neutrophils. They can all suggest patients developing sepsis. We should routinely do renal function and liver function tests because any derangement in that is telling us that organ failure is developing. And the earlier we catch it, the earlier we refer it, the earlier we escalate the treatment, the better the prognosis is. Lactates is now a norm in all the hospitals nowadays. It is a marker of tissue hypoperfusion, and lactate more than 2 or especially more than 4 tells us that the septic shock is there and the prognosis is much worse. But you should also remember that any patient who is having anaerobic metabolism or delayed liver injury is there and delayed clearance of lactate is there, they also lead to increase in the lactate levels. So no biomarker, nothing is perfect. We should all take that into relevance in the clinical condition. Similarly, procalcitonin, which is now being used in almost all setups, and the normal level is less than 0.5 nanogram per ml. It is used to distinguish bacterial infections in which it is stimulated by bacterial endotoxins and cytokines. The levels are markedly high as compared to viral infections, which suppresses the procalcitonin via interferon gamma. So usually it is a very early marker, that is why it's used. And remember, the trend is more important. A single value is not that important, although single value more than 0.5 is suggestive of bacterial infections. But usually in all the studies and literature that has been done, it has been seen that the trend, increasing trend, is they're telling you that the patient is getting sicker, and a decreasing trend is telling you that the patient is getting better. And in various studies it has been used, a decreasing trend has been used to de-escalate antibiotics, the intravenous antibiotics in various hospital studies. CRP again is an acute phase reactant produced in the liver in response to inflammation and is primarily stimulated by interleukin 6. So this is called C-reactive because it is binds the C polysaccharide of Streptococcus pneumoniae, and it was used very commonly prior to developing of procalcitonin, but now procalcitonin is used more in the hospitals. And we all know that CRP is a marker of inflammation and not infection, and many other causes of inflammation will also lead to rise of CRP. Now, blood culture should ideally be drawn before we do antibiotics, but antibiotics, at least in septic shock, should not be delayed by more than 1 hour. So if you can possibly take blood cultures, it is well and good, but it should not delay antibiotics. And worldwide, the sensitivity of blood cultures coming positive is to the tune of just 50 to 60%, not more than that. And usually previously it was using around 12 to 48 hours to identify the organism on blood culture and then further time to check the sensitivity. But now there are newer developments in molecular and rapid diagnostics, the PCR-based panels, the MALDI-TOFs, it detect the bacterial DNA, and the results and the enzyme mechanism and genetic mechanism that are leading to resistance. So in hospital, we find a lot of patients who are having resistance to some or the other antibiotics. Even those mechanisms can now be judged in just few hours. So this development in AI and molecular rapid diagnostics has been there in the last 2 or 3 years, and it is progressing very, very fast. Similarly, MALDI-TOF is another way in which can rapidly identify the organism once the blood culture is positive. And nowadays, newer organ-specific biomarkers are being developed. So if a patient is going to develop a kidney failure, you can do a biomarker and try to identify it early and not at the later stage of kidney disease. And all the, when we talk of monitoring a patient in the hospital, we use AI to monitor nowadays all the things that are monitored electronically. The AI-specific algorithms are there. So you can identify the patients who are going into a shock or who are having a worsening of sepsis so that they can be moved to the critical care setting. So now AI-based early warning systems are being developed so that the patients are identified early and they do not have organ failures. Imaging has also progressed, so now ultrasound is almost the standard of care in all the hospital setups, especially in critical care, and all the intensivists are now doing the ultrasounds and echocardiography almost by themselves, at least at the patients who are hemodynamically unstable. And we need to do that at the bedside, and we do repeat the examination. So it's a non-invasive examination ultrasound, and we can repeat it as much as possible. It is difficult to shift a patient of sepsis and septic shock, especially to a CT scan or a MRI, but when required, we have to do that under monitored settings. When I talk about management of a sepsis patient, resuscitation is the foremost. So we are always taught that the airway and breathing should be paramount. Any GCS less than 7 or 8, we need to think about intubating a patient and maintain the oxygenation status. We should need to watch the respiratory rate. Any patient going into bradypnea, decreased respiratory rate, he might require intubation. So we have to be very careful. And nowadays, we have a non-invasive ventilation and HFNC to supplement the endotracheal intubation and invasive mechanical ventilation. So resuscitation, circulation, and fluid resuscitation is a very, very important thing in sepsis. So any patient in which you feel that he's going into organ failure, we need to give them fluids because the septic patient usually is vasodilated. So there's a relative hypovolemia in these patients, and we need to treat that by giving him IV fluids. So nowadays we do a echocardiography and ultrasound of the lungs to monitor how much fluids we need to assess and give to the patients, and we send blood samples as early as possible. So, and we need vasopressors, so we give them vasopressors as much as required when it is required. But fluid resuscitation is a very important thing, and how to monitor that is also very carefully done. We give early and appropriate antibiotics, and this depends on the source of infection, whether the patient is having a community-acquired infection or a healthcare-acquired infections, the local resistance patterns, and any organ failures that we need to modify the antibiotic dose for. Two subset of patients in which you need to be very careful in the elderly which do not present as fever and the immunocompromised because it deteriorates very, very fast. So as a take-home message, we should think sepsis is infection plus the patient is having abnormal vitals or the patient is looking too unwell. Second is that we need to, in the first visit on the patient, we need to monitor his vitals including heart rate, BP, mentation, and take a history of urine output. We should act quickly and escalate a patient if we find any features of shock or organ dysfunction. Nowadays, we should remember the faster pathogen resistance detection methods are available, and early and adequate resuscitation is being developed, done in the hospital setup using the ultrasound and the echocardiographic machines. And appropriate early and rational antibiotics is the key. So if time permits, I'll ask just a couple of questions to all of you. A 60-year-old woman with UTI presents with a temperature of 100 degrees Fahrenheit, heart rate of 118, BP of 94/60, and new confusion. What is the most likely diagnosis? Yeah, sepsis. And secondly, a 70-year-old diabetic male presents with cellulitis. He has febrile with temperature of 99, a heart rate of 110, BP of 102/68. He is drowsy. Which of the following should trigger suspicion of sepsis, and we need to trigger it to higher escalation? Altered mentation, yes. So that is why I want to highlight altered mentation is very important to us. And a big thank you to all of you for the trust that you've shown to us. Thank you so much.
Thank you, Dr. Saurabh, for an excellent exposition. We can have two questions quickly. None. May I have the opportunity of asking you a small question?
Yes, sir, please.
we have immune compromised patients coming to you. Like you mentioned that those patients may come in a little altered sensorium, but they may be also having a CNS involvement. So how would you differentiate briefly in between a sepsis versus an active disease as far as our maybe a lupus is concerned?
Sir, very difficult. We have to treat both of them because sepsis in these patients is also making them very critical. So we have to cover for the antibiotics, and actually we'll have to take a response, and we can do a imaging as well. So MRI would help us. Some lumbar puncture will help us if required, and if they can be shifted. Plus, we need to cover if they're immunocompromised. We need to cover them with antibiotics, even if we suspect that the infection probably is lesser chances. So we have to take care of that.
Thank you very much.
Thank you so much. We have a slight change in the program.
Sorry.
Thank you to the chairpersons and the speaker. Our next session is going to be on liver fat and underperceived danger. Fatty liver is on the rise, a silent but clinically significant entity, and it is often under-recognized. And how early intervention can help us, Dr. Sandeep Bhagat will enlighten us on this session. For this session, we have our chairperson, Dr. Praveen Sharma, Dr. Ashish Kumar, and Dr. Anil Kumar Agarwal. I request the chairpersons to join me on the dais.
Good afternoon, everybody. In fact, I was just going through the schedule. This talk has been preponed a little bit. The 3 lectures which were scheduled prior to me were Artificial Intelligence in CT scan, Novel Therapies or in ID, Smart Clinical Decision using medical apps. In fact, I was wondering myself, when everybody else is talking of new innovations, technology, AI, robotics, why am I talking of such a simple topic of liver fat? I think it's because we have been taught that prevention is always better than cure. And it's not just my own idea. Even Prime Minister Mr. Narendra Modi ji, Neeraj Chopra, Dr. Devi Sethi, Nikhit Zareen, and many other celebrities also believe in this belief that prevention is better than cure, and we can act at the time when we can change the life for a better future. In fact, in last year, 2025, Modi ji has advocated for 10% less consumption of oil for the better health. This was February 2025 in Man Ki Baat. He promoted that thing. And in 2021, Government of India has also integrated NAFLD under the National Program for Prevention and Control of Non-Communicable Diseases. And in collaboration with ILBS, DGHS has released operational guidelines for NFLD under NP-NCD. So my only disclosure is that I'm delivering a awareness talk. NFLD or MASLD. The previous nomenclature was NAFLD, which used to tell us that there is a fatty liver disease which is not because of alcohol intake. But now the nomenclature and our understanding of the subject has changed, and we have included metabolic parameters which are the key drivers of fatty liver involvement. And it has been seen that almost 1/3 of the global adult population is suffering from NAFLD or MESLD. The inclusion of metabolic factors is very important because this is a combination of multiple factors which are affecting. It's not just a single disease. Like I cannot just be like I'll focus only on the fatty liver. For other hypertension, CAD, diabetes, obesity, you manage your own. It cannot be like that. It has to be a team effort, and it is a integrated approach which can help the patients. Why did we say that it's a silent epidemic? Because most of the time there are no symptoms, and often it goes undetected until irreversible damage has already occurred. Almost 25 to 40% of global adult population is suffering from MASLD. In 2021, there were estimated 1.2 billion people who had NFLD, and this was a steady increase of almost 24.53% since 1990, and NFLD has now become the most common cause of chronic liver disease worldwide. Indian situation is very much alarming. In fact, if we see the region-wise prevalence, it varies from 9 to 53%. But adult Indian population, almost 38% are suffering from MASLD. And it's not just the adult population, even almost 34% of our pediatric population, children, they are also suffering from MASLD. There was a recent survey by ICMR who studied presence of NAFLD in urban professionals of Hyderabad, IT workers, and they found that almost 80% of them were having fatty liver or NASH. And the main reason was our lifestyle. If we, and when we are in the North India, we are the one who have the maximum burden of the disease. Why did I say so? Because almost 70 to 80% of North Indian population are having the adult population. The incidence of MSLD is quite high. The highest incidence is in Uttarakhand region, and the reason is rapid urbanization, sedentary lifestyles, more intake of calorie-rich processed food, lack of sleep, pollution, and lot of other things. And again, one more very important fact is that India is a leading population who is suffering from diabetes. 2024, there was a paper in Lancet which showed that 212 million people in India are suffering from diabetes. This is the data which says that lot more are undiagnosed also. So the Indian population, that the load of diabetes in India is far, far, far from what we have already picked up, and it's a part of metabolic disease. And similarly, almost 70%, 60 to 70% of our diabetic patients, they are having underlying MAFLD. Another very important thing is the body habitus. The body habitus of Indian males as well as females is such that we have central obesity, or the more of visceral fat, and we have underlying insulin resistance. This also predisposes us to MAFLD. One very important fact is that for the South Asian population, the parameters of BMI, which used to be like 25% for Western world, has been reduced to 23% for Indian population. So at the same amount of weight, or at the less BMI also, we have more central obesity, visceral adiposity, and we are more prone to develop MSLD. If you are a normal weight, that doesn't mean that you cannot have MFLD, because 6.5% of the lean population of India is also suffering from underlying metabolic disorders and visceral adiposity, which predisposes them for. This is an identity which is called lean MSLD. Indian prevalence among the, if you see, the almost 16% of our MFLD patients are normal weight. So this is a special entity, lean MSLD, which I thought is worth mentioning. Then how does this disease progresses? Initially, liver usually contains less than 5% of fat. When the fat accumulation is more than 5%, it starts accumulating in the liver, and liver cells start swelling up. This is a stage when we call that this is a spectrum of the disease, which starts with initial microvascular fat, and then they start accumulating and cause ballooning of the liver cells. So steatosis, which initially starts as a benign disease, is a potentially dangerous disease. As it develops, it progresses to 30% of it progresses to MASH. MASH is when there is an inflammation and the liver cell injury starts. And when this liver cell damage starts, the liver cells are replaced by collagen cells. So gradually the fibrosis starts. When the liver starts getting this fibrosis, gradually over the decades, we progress towards the cirrhosis, and all the signs of end-stage liver disease becomes evident. Almost 2.4 to 12.8% of patients with cirrhosis develop SCC in patients who have underlying MASH. So it is very important to pick up this disease early and treat it accordingly, because the initial stages of steatosis and NASH with mild fatty liver, they are reversible. So the metabolic factors that we have, I'll just skip it through fast, because these metabolic factors are to be mentioned as well as to be addressed when we treat these patients. BMI more than 23, fasting glucose more than 100, blood pressure more than 130/85, then plasma triglyceride more than 150, HDL less than 40. These all leads to progression of MSLD to MASH. And similarly, and when there is a progression from MASH, MSLD to MASH, MASH itself causes increase in the complications or leads to risk of new onset adverse events, like almost 2 times more development of neuro onset diabetes, then cardiovascular events 1.5% times, heart failure, atrial fibrillation, CKD, and risk of extrahepatic cancers, and it progresses to cirrhosis and SCC. So beyond the liver, almost the leading cause of death in patients who have underlying MSLD is cardiovascular, it's not liver. The initial, there is 25% mortality is because of cardiovascular events, and there is almost 75% of the diabetics have MSLD, and the MSLD itself increases the risk of development of neuro onset diabetes. Liver cancer, as I said, almost 50% of the patients who have underlying MSLD develop liver cancer without the development of cirrhosis. Usually the timeline used to be like initially MFLD, then MASH, and then fibrosis, cirrhosis, and then cancer. But almost 50% develop without underlying cirrhosis. And there is extrahepatic complication, as I just mentioned. So why it goes undetected? Because most of these patients do not feel any symptoms. There are subtle fatigue or discomfort that is easily overlooked. And there are no guidelines for the general population screening. We have normal LFT. We can pick it early by doing tests like FIB4 on our clinic only. And if the FIB4 is more than 1.3 or more than 3.2, that shows that there is significant fibrosis. And if there is if it is more than 1.3, then we should screen the patients by doing a elastography. And it's just because the early you pick up, the early intervention we start, and then the more easily we control the thing. So if there is a time now for a change. Change is very simple. We need to watch what we are eating. It's not just the quantity, the quality is also important. And we have to lose the weight. Control of weight less than, if you can reduce your weight by 5%, it significantly improves ballooning and early fibrosis.
Dr. Sandeep, we are exceeding time.
Yes, sir, I'm just gushing through. And if it is more than 30, so maintain a healthy lifestyle, do a regular exercises, say no to alcohol, and coffee, black coffee might help. And This is the time to act now. The MSLD is not just a liver problem, it's a systemic metabolic disorder at the heart of the global non-communicable disease crisis. Early detection and the lifestyle modification remains the most effective intervention. The window of opportunity is closing. We must act before the silent epidemic becomes an irreversible catastrophe. I wish you all a very happy and safe liver. Thank you.
Thank you, Dr. Sandeep. He actually summarized very well. Fatty liver or MASLD or NAFLD is very common. Two most important risk factors are obesity, that is abdominal obesity, if your abdominal girth is high, and the other is diabetes or pre-diabetes. And we all encounter patients who come with different complaints, maybe some with gynecological problem, with some with any other problem, hypertension, heart disease, and we often encounter patients who come with that their ultrasound shows fatty liver. So fatty liver is not benign, we should not ignore it. We need to screen them for all these cardiometabolic risk factors, and we also need to screen them for liver fibrosis. So for fibrosis, a fibroscan test is important, but if a patient cannot afford that, a simple FIB4, which is available in all of your smartphones, can be done. And if a FIB4 value less than 1.3, exclude significant fibrosis. But if it is more than 1.3, then we need to go ahead with fibroscan. And if it is very high, more than 2.67, we need to refer these patients to a gastroenterologist. So we can have maybe one or two questions, and
I think.
It's actually a very early marker for many diseases, especially NCD and especially cardiovascular. And the big problem is the fibroscan machine is hardly available. It's which premier hospital has fibroscan? Some companies actually moving around, I will not name the company, carrying the machine to some of the hospitals, premier ones. So the biggest problem is because ultrasound misses it early, and early detection, if I can make the patient aware of it, means I can push my lifestyle. But the problem is the cost of the machine. And how many places does it? I can't send them to a gastro center of Bangaram, which might have its own machine. Very few, only 2, 3, 4 centers might have it. So what is the solution?
So I understand that as I mentioned, that FIB4 score is very simple and OPD based thing, that you just have to see the AST, ALT values, the platelet count, and the age of the patient. That gives you a fair indicator whether you are ruling in the significant fibrosis or you're ruling out significant fibrosis. Only thing is, in fact, the ultrasound also can do a shear elastography. It can give you a fair idea how much, but definitely there are.
Picking up with the liver, आपका ये भी नहीं FIB4 score भी नहीं शायद देगा, वो तो fibrosis देगा. So the marker is, it's actually the statins, the way they are being pushed. This should have been one of the earlier tests being done, but unfortunately, I'm not sure if there are any machines which can help me diagnose.
See, once liver has got fat, the liver outcome is determined by fibrosis. So once you find fat, you have to exclude fibrosis. The blood test for fibrosis is FIB4, which is simple and available, but it has also its limitations. So if FIB4 is high, then possibly you will have to get some certain other tests, which would include fibroscan, or even ultrasound has got shear wave or certain tests. And if FIB4 is very high, definitely you'll have to refer these patients. And if the liver has fat, he also has other cardiometabolic risk factors, hypertension, BP, and all that. That needs to be ruled out.
I think, Sandeep, excellent talk, and I can just add a surgical point in this, that fat is important when we are taking up patients for surgical resection from the liver point of view, because I think, as he said in one of his points, that it is not just the quantity of liver remaining, also the quality of liver. So if the fat is there, then we have to factor in a higher percentage of remnant liver for resection, and maybe take the help of Arun, Raghav and their team to do augmentation techniques to enhance the liver. So I think it is important from all points of view, medical management, and then it has a very important bearing on the surgical management, because like in fact, you might have heard about the cash. which is chemotherapy-associated steatohepatitis. I think that itself, what was resectable earlier, may become unresectable, or you may need a liver augmentation technique. So I think that is what Praveen.
I think, but the most important thing here is the lifestyle management, which we all miss and we all underrate this thing. So if you manage your lifestyle, everything will get better.
I think we should close this
Yeah,
session.
sure.
It's an interesting session, but we are exceeding time, and it's better to close it. Thank you.
Thank you very much. Discussion can go over a fatty meal in the lunchtime.
Medical College and also All India Institute of Medical Sciences, Urology. So I am coming back to Delhi, and I request you, along with Dr. S.L. Gupta, who also many of our colleagues are sitting. I am contesting for DMA President election on 8th February. So I need all the blessings, wishes of all of you, and to serve you. I am always there, and with my experience, I am sure I will be able to do justice to your expectations. Thank you very much. Dr. S.L. Gupta will also address.
सबसे पहले तो आप सबसे क्षमा चाहता हूं इस क्लिनिकल सेशन के बीच में डिस्टर्ब करने के लिए, पर बहुत ज़रूरी हो जाता है अगर आपका एक लीडर बिटवीन वन ऑफ यू गोइंग टू डीएमए प्रेसिडेंट, सरकार और आपके बीच की एक कड़ी के रूप में दिल्ली मेडिकल एसोसिएशन का अध्यक्ष चुनते हैं। आप सबसे गुजारिश है कि आप 8 फरवरी को Dr. Rajiv Sood as a president of Delhi Medical Association, Dr. G.P.S. Garewal as a vice president, and Dr. Mrs. Lal Chandani, another vice president. Election time is 8 a.m. to 5 p.m. And I'm seeing here different branches of people, they are from different areas. So centers accordingly. For the Central Delhi and Karol Bagh is, of course, is a Delhi Medical Association Hall. For South Delhi is the Lajpat Bhavan. So different centers are different doctors. Thank you very much. Thank you.
Thank you. वोट डालने जरूर आए घर से और अपने फ्रेंड्स को भी लाएं. Thank you very much. Thank you.
Now for the next set of sessions, I would like to request Dr. Biotra, Dr. Atul Gogia, and Dr. Kishan Rawat to join us on the dais. Our next session is actually quite interesting and need of the hour. As AI is taking over everything, we should know how AI is affecting radiology as well. So we have Dr. Anurag, who's going to discuss how AI in CT imaging enhances accuracy, efficiency, and clinical decision making. Welcome, ma'am.
Good afternoon, everybody. Again, welcome to our next session. I'm sure you are all enjoying, and after having had a good discussion about fatty liver, well, we are going to have artificial intelligence is really taking over. Whole thing is not only medical, all the profession. You are seeing every day at the homes, everywhere you use apps and everything. For AI is one of the things taking over. And in medical, so medical imaging has the actually maximum impact on this, and they have the in time to come, maybe another 15 to 20 years, almost everything will be patient come and talk to you, and we are just putting on a artificial intelligence. Probably at the end of thing, this intelligence going to tell you, but the near almost diagnosis, what investigation, how to treat, everything is going to. I think we are going toward the AI. Well, now I introduce, it's my privilege to introduce Dr. Anurag Yadav. She's the chief of CT scan in Sir Gangaram Hospital. She's there associated with us for over 20 years, and she has one of the pioneers in the country for who's using artificial intelligence in the management of CT imaging. Well, I'm sure she's going to make the thing, especially CT angiography, coronary angiography, and all. We have right pioneered in the country. I call upon Dr. Anurag to please start a deliberation.
Thank you so much, sir.
Artificial intelligence in CT imaging.
Thank you so much, sir, for the kind introduction. I'll just be talking very briefly on the AI in imaging. I'll touch upon both CT and MR for that. So we have the sessions dedicated to sharper diagnosis and smarter treatments. AI can transform technologies and reshape diagnosis. The data driven by AI can lead to precision size science and enable personalized medicine. So which is the need of the hour. Like one diagnosis is not there for everybody. The intelligent systems work synergistically with the clinician to enhance the decision making and optimize patient outcomes. So how does AI work in radiology? We have large labeled imaging data sets which can identify complex patterns and subtle abnormalities very reliably. Like radiology is not about what is black or what is white. It is trying to find out the diagnosis within the gray zones. So those are very well picked up if taught to the AI. The performance of the AI will depend entirely on the data set on which it is trained, which has to be very similar to the clinical population on which it is deployed. It excels at reproducible tasks, which are very laborious manually, and it generates quantitative outputs. So why does CT, out of all the imaging modalities, lead in adoption of AI? More or less, the CT protocols are quite standardized. They are consistent, and they can be reproducible. And a large number of annotated data sets are available widely for training and for validation. So these help in employing AI for emergency as well as for screening CTs. So the AI can select the protocol, like depending upon the habitus of the patient, or the imaging parameters depending upon the indication of the study. It can automated detection of motion, that is if there are any respiratory or cardiac artifacts, and reduce the repeat scans. It can employ adaptive iterative reconstructions, that is it can reduce the noise and improve the image quality even if the radiation is lowered by 30 to 40%. It provides better soft tissue visualization even in low dose scans, and this benefits the pediatric population, and also very useful for screening CTs, which we do at low doses, and maintains the diagnostic accuracy. AI is being used very much and is the talk of town, especially for emergency CT triages. We must have, all of us must have seen that advertisement very recently, that AI-read chest X-rays in All India Institute will be, giving your diagnosis in less than a minute. So AI in CT also can pick up the time-critical findings on a very urgent basis. It can flag the studies. Okay, these are the studies which have the findings, and can, draw the attention of the radiologist to first go through those studies. Say, for the example, in this study, this is a 68-year-old man and had an acute stroke. It flagged a hyperdense MCA. Hyperdense MCA means there is a thrombus in the right MCA, and a thrombolytic therapy could be instituted within 45 minutes of the scan. Similarly, intracranial hemorrhages, AI is exceeding 98% to pick up intracranial hemorrhages and flag the studies that these need to be looked at. Similarly, for pulmonary embolism, it doesn't pick up the emboli just in the main or the lobar or the segmental arteries, but as in this case, even in the subsegmental arteries, you can see the pulmonary embolism being picked up by the AI scans. AI is used very majorly for the cardiac CTs. As I said, I have a personal very interest in coronary angiographies, and we are using AI for all these technologies. There is an automated Agatston scoring which AI can do. So we do not have to manually place the ROIs, and it gives a vessel-wise scoring, enabling the risk stratification. It can automate the curved MPRs, differentiate between the different plaques, that is whether they are lipid-rich, fibrous, or calcified, and even the plaque burden. It can be integrated for automated lumen analysis. It is the 40 to 70% or the intermediate stenosis, which are very reliably picked up by AI and quantified. Then FFR, like we all know, is a part of cath angio, but is also done on CT by the same data set that we acquire for a coronary angio. It is, however, very expensive. It is a patent by Heartflow. It is very difficult to get and it is very expensive. But now with AI incorporated into the CT scanners, we can bring down the cost very substantially. As we can see in this patient had a 55% LAD stenosis, and AI derived an FFRCT of 0.72 and an angiography could be obviated. Similarly, we can integrate this data that we have on the AI-derived coronary angiography to the catheter, to the cath lab. So the angles at which we pick up the stenosis best are provided to the cath lab, and the automated fluoroscopy angles can be used, reducing the fluoroscopy time and the contrast load very significantly. It, however, has its limitations because of motion and respiratory artifacts, high and very variable heart rates, and heavily calcified vessels. AI in MRI has a myriad of applications, but basically, I'll just tell you that it enables, they're AI-enabled MR coils, which are flexible, lightweight, and fit as a blanket. They use the deep learning algorithms, and when associated with AI-enabled MRI protocols, they even leverage the machine learning algorithms, accelerate the scan times, and improve the image quality very vastly, and automate the workflow. So the time-intensive scans, which used to typically take 30 to 60 seconds, can be finished in under 20 minutes, especially the pediatric MRIs, brain MRIs, and can reduce the requirements for sedation. We have something like the AI-accelerated diffusion and the perfusion images for acute stroke. These can pick up, as in this case, we see a 58-year-old man presented with acute aphasia. These fast MRI sequences with the AI detection could pick up a Broca area acute infarct in less than 8 minutes, and the institution of therapy was easy. One major area where AI is useful is in monitoring of chronic diseases. You know, it becomes very difficult and very time-consuming and exhausting for a radiologist to manually keep comparing follow-up scans, especially in patients with multiple sclerosis or with ILD or adult polycystic kidney disease, which they are getting scans done at a very good frequency. The precision is becoming very routine with AI. I'll just show you. See, this is a patient with multiple sclerosis, and AI could pick up 3 new T2 foci, comparing the right to the left images, and also an enlargement of one of the focus. So AI flagged it within 2 minutes, which is really difficult. You know, you have fed in the previous scan. The AI will take the same protocol to scan so that, you know, like you get the identical results, and it will compare the sizes, the enhancement pattern of the lesions, whether some of the lesions have appeared, new lesions have appeared, some have disappeared, and the changes in the enhancement pattern of these cases. In ILD, picking up the subtle fibrotic changes, or in this patient with adult polycystic kidney disease, it can pick up the new number of cysts that have developed or the size change. In organ segmentation, it can also help with liver segmentation, pancreatic segmentation, especially in patients with chronic pancreatitis. You see, this is the way it will depict the liver segmentation. And on the right side, we have the pancreas segmentation. Low-dose CT, when performed with an AI module, can exceed almost 96% of, it has a 96% sensitivity. So with these kind of changes, and if you integrate, it can be also used for 3D and 4D models, which we are using for congenital heart disease. You can have the heart in your hand, and the cardiologist and the cardiothoracic surgeon can actually plan the entire surgery, or for hemiarthroplasties. So the medium end scanners, which most are used in India, can work as a high-end scanners. We are using computational and fluid dynamics and integrating it with PACS. We are also doing the reporting by AI. We are on a regular basis in our department using Ogneto and now Quiller. in which you can give the dictation in an unstructured format in almost 60 languages and a mix of languages. It will take up the entire dictation and give you a structured report, and the reporting time can be reduced to almost 40%. And when integrated with PACS, it really is making things faster. But all this needs a validation by the radiologist. So we need to have an integration of multimodality. The AI can detect and also confer with the radiologist. AI can focus on reproducible tasks, and it is not that AI will replace the radiologist, but the AI integrated radiologist will definitely replace the traditional radiologist. At the end of the day, you need a radiologist to validate the reports. Thank you.
Thank you, Dr. Anurag. I need 2 questions.
Yes, sir. Ma'am, cardiac CT angiography is a very important development for future. With AI, there are 2 questions. One is the high-end CTs are very less available in very of the few hospitals, and they are quite expensive, although they are there. Does AI make the previous old generation CTs more relevant so that the cost comes down? Secondly, where are we close to the angiography? Can, with the usage of AI, can we outbeat angiography, the gold standard? In cardiology, it can change practice area.
Yes, sir. I think both the questions, the answer is yes. See, in India, most of the scanners, the CT scanners, range from somewhere from 5 crores to almost 18 crores. You know, but in India, we are quite cash strapped and we have to maximize our resources. Most of the scanners are in the mid-range that we are using all over India. There would be about 7 to 8 crores. But with the help of AI, we can have those protocols. We are using softwares in which they can probably not mimic an 18 crores, but it will have all the features of quite a high-end machine. So all those challenges we had that, okay, only the 18 crore machine will do a CT angiography in single heartbeat. Now we are doing it in 4 heartbeats, but we are getting the same kind of results. That is question number 1. Yes, definitely with the use of AI, we can use the medium-end scanners to high-end scanners. Plus, all the new scanners are coming with the same basic hardware, irrespective of the kind of protocol, the softwares that are put on it. So it can be upgraded to a high-end scanner at any point of time. And the second is that, are we very close to catheter angiography? Yes, we are very close to catheter angiography. If we have our patient selection, which is done properly, and we take a lot of time in educating our patients, like how are we going to go about the scan. We train the patient, we do a proper breath hold for the patient, we get the heart rate to an acceptable level, and our results are very much comparable with the catheter angiography, because the moment we say that there is a critical narrowing, it doesn't take more than an hour or 2 for the patients to be taken up by the cath lab.
I think we can have more questions at the lunch break. Because dearth of time, we'll move on. Thank you, Dr.
Thank you, Dr. Anurag.
Thank you, Dr. Anurag.
Thank you, ma'am, for telling us that AI is smart, but radiologists are smarter. Definitely. As we move on to the next session, which is regarding medical apps, smart clinical decisions using medical apps. So Dr. Shipra Gulati will demonstrate how digital tools can support smarter, evidence-based clinical decisions without replacing clinical judgment. Welcome.
A very good afternoon, everyone. I'll be briefly talking about the smart clinical decisions which we can make using medical apps. So why do we need to upgrade ourselves? We as physicians manage about 50 to 100 plus patients on a daily basis in both OPD and IPD. Memory-based decisions are related to 3 kinds of risks. 1, increased diagnostic errors. 2, missed drug interactions. And 3rd, dosing errors. Also, guidelines are constantly updating and manual recalls are quite unreliable. So it would not be wrong to say that clinical decision support system, that is CDSS, is the future. What are the expected clinical outcomes with use of CDSS? About 15% decrease in medication error, 47% increase in better recommendations, and about 20 to 30% decrease in the decision-making time. CDSS impact on patient outcomes. Behavioral outcomes, about 47% improvement in appropriate therapy recommendation and tests ordered. Patient safety, there's a 15% reduction in medication error versus the usual care. Diagnostic accuracy is 82.6%, which is about 12% higher to without using the medical applications. And it provides a confidence boost with app support. This data has been published in PTT advisory study in 2024. So what are the applications of CDSS doing? They provide diagnostic support. They provide accurate use of criteria for medical diagnosis, clinical data and management, cost containment, and help us in drug selection. Now I'll be covering a few apps that we commonly use. First, being up to date, which is quite common and all of us have been using it. It provides a deep evidence-based review with graded recommendations. And the plus point is that it's regularly updated. It is best used for diagnostic algorithms, management of controversial diagnosis, and exam viva answer reference for students. So there's one limitation with UpToDate, that the data is less India-specific. Next, Medscape. It is a quick bedside answer application. It provides drug monograms and drug interactions. It is best used for on-call drug dosing, disease overview before rounds. The limitation, again, is the data is less specific to India. BMJ Best Practice. It is a symptom-based differential diagnosis. It clearly identifies the red flags. It is best used in emergency settings and helps students to write structured answers for exams. And a unique strength in this application is that it provides a patient leaflet that helps counseling of patients. Next is Pathways. As the name suggests, it provides a visual step-by-step algorithm. It is best used for systemic evaluation of patients so that we don't miss out on tests. And the strength is that it mimics real-life scenarios in which you're kind of presenting a case to your senior. Huma Helper, as the name suggests, it provides a complete toolbox for classification, criteria, and disease activity scoring for rheumatology patients. Radiopedia, Madam has already discussed this in detail. These are imaging pattern recognition. It helps understanding, interpreting CT, MRI images. It is very good for students per se. Visual diagnosis. It is an image-driven differential app. It is best used for dermatology and rheumatology for identification of various lesions and rashes. MedCal. This is another set of applications which provide us calculators to analyze the various risk scores with study references. It helps in staging and grading of disease. So here we have a tip that if on our prescriptions or our students in our answers, we quote the scores, it provides a better impression of our understanding. Epocrates. It is a drug-drug interaction checker. Now, polypharmacy in elderly, patients in the ICU who are on multiple drugs, we often miss out on common drug interactions, which can pose a lot of problem. Apps like this are quite helpful in eliminating that risk and increase patient safety. Lexicomp is another drug interaction checker. It is one of the most detailed database available for drug interactions. Clinical Key. It is a reference app. It has access to various books like Harrison's, Brownwald, etc. It provides access to full guidelines and review articles. It is best used for thesis literature review, for making presentations, and for reference for exams. Next, we have applications that provide us with the latest guidelines, like IDSA. It is the gold standard infection antibiotic guideline. It is best used for management of infectious diseases and also provides antibiotic stewardship. Stanford. It is a pocket antimicrobial reference guide. It is best used for the choice of empirical antibiotics and resistance-driven medical decisions. Since we cannot cover all the apps in details, I've made a list of the apps specific to various systems that we can use.
Thank you, Dr. Shipra, for excellent talk. So we have...
Also, I would like to take this opportunity to announce that the Department of Medicine, Sir Gangaram Hospital, is hosting the 37th medical update on 1st of March at Shangri-La Hotel. Anybody who wants to register, the brochures are available at the reception desk. Thank you.
Thank you, Dr. Shipra, for excellent talk. And
we have enough time for questions. So I think we can take 2-3 questions because we still have time. Please, sir. Dr. Dugal.
Thank you. It was excellent. But one little thing, when you're seeing a patient and you're stuck with a problem, you can't go to the apps. So best is like we do, excuse yourself to the washroom. While you're there, you open up the chat GPT and that gives you an answer, or even maybe the Google.
Thank you, sir.
The labs has made life very easy for all. We in the round, we say some of the resident, now try to find out which drug is best for you. And interaction, I think they take up their phone and they tell you immediately. Lot of things of breathing, of books, and they are really things of the past.
So best apps that we use are UpToDate, Medscape. But for every specialty, there are different apps. And I would suggest that using apps for drug interaction checking and calculators is of utmost importance in clinical practice.
Diagnosis and treatment.
Ma'am, these apps are usually updated according to the latest guidelines, and most of them are weekly updated. So this actually helps us reduce the errors.
Could use ChatGPT, ask for the error rate also, and a column will give you that and annotate it. So you have a two-sided risk analysis. Nothing is without error, so ask for the error rate.
At least you know about AI, don't know about radio.
Ask anything, ask for the error rate, please.
Thank you, everyone.
Thank you, Dr. Shipra.
So moving on to the next session, with evolving pathogens and resistance patterns, treatment strategies are changing.
Can I update, sir? Google has introduced very new app, that is Google AI Medicine.
So there are more and more apps which are going to come. We can discuss them over lunch.
So with evolving pathogens and resistance patterns, treatment strategies are changing. Dr. Anvita will update us on novel therapies in infectious diseases relevant to current clinical practice.
Dr. Anvita is a consultant in infectious disease at Sir Gangaram Hospital. We have a separate section in the Department of Medicine, the Department of Infectious Disease. And we have our senior consultant, Dr. Atul, and she is also consultant with the Department of Infectious Disease at Department of Medicine, Sir Gangaram Hospital.
Thank you so much for the lovely introduction. So I've been given 10 minutes to talk about what is novel in infectious diseases. It's a huge, huge list. I can probably give a glimpse of a few 10 most important in the next 10 minutes that I talk about. So if we go from 2016 to 2026, we have come a long way from toxic therapies to precision-based, evidence-based therapies. We used to essentially target safety and survival to begin with. Now the paradigm has shifted to more of improvement, quality of life, shifting to lesser drug pill, shifting to more precision-based medicines, and trying to preserve the host rather than exploding everything on that bug. So the landmark studies that have happened and developments that have happened in HIV, I would love to talk about these. So in 1980s, when HIV was considered to be a death sentence, it has now come a long way to once a daily pill, which is very easy to take, to a new shift towards injectables. So newer injectables have come up, which are cabotegravir with rilpivirine combinations, which can be given once every 2 weekly. They have shown to have very good virological suppression and sustained virological suppression in most of the individuals. Additionally, a new class of antivirals for HIV have been introduced, which are the capsid inhibitors. So lenacapavir is one such drug, which is rather dosed for once in 6 months. Can you imagine, from a deadly drug, from a high side effect toxicity treatment, we've come to 6 monthly treatment options. And not just for treatment of HIV, but also for pre-exposure prophylaxis and HIV prevention. Lenacapavir has shown to have a very significant efficacy when it comes to comparison with the current pre-exposure prophylaxis medicines, and it really broadens our perspective towards patient-driven and comfort level care approach. Now coming to MDR tuberculosis. So MDR tuberculosis is a major life threat. It has very high mortality, morbidity, more so because of the treatment options, which are so toxic, which are so difficult to tolerate. So as long as 2 to 3 years ago, we had the only option was long all oral or long injectable based regime for MDR tuberculosis, which comprised of almost 2 years of therapy with multiple injections of drug toxicities like amikacin, kanamycin, and a lot of drug adverse side effects. And even then the mortality rates reached to as high as 50 to 70%. Now recently WHO has made a new standard of care, which is a 6 months tablet based regime, which is the BPAL-M regime, comprising of bedaquiline, linezolid, moxiflox, and pritomanid. This 6 monthly regime is a wonderful game changer in MDR tuberculosis treatment, which makes it much easier, tolerable, much easier in terms of the patient's duration of treatment, and very less toxicity. Taking this forward, we have further regimes which are coming up for approval of even XDR tuberculosis, comprising of bedaquiline and delaminid based combinations, and sorafenibulin. This is the newer drug which has recently shown higher potency than bedaquiline, which is now promising ultra short regimes for MDR tuberculosis treatment and even drug sensitive tuberculosis, almost ending the whole treatment duration to as short as 1 to 4 months. So these are phase 2, phase 3 trials which are ongoing, which are going to be absolute game changers for MDR tuberculosis. So in the previous sessions, we've heard about sepsis, we've heard about various drug-resistant organisms which are causing a havoc, especially in our ICUs. Gram-negative sepsis is a major threat in Indian society currently. Acinetobacter being one of the major threats. We have sulbactam, durlobactam, which has recently been approved for VAP and HAP in Acinetobacter MDR options. However, it's yet to be available in India. It has very high efficacy as compared to colistin-based counterpart regimes. Cefepime N-metazobactam. This is a wonder drug which has recently been approved by FDA for UTIs against E. coli. E. coli being one of the most dreaded bugs in community-acquired UTIs and hospital-acquired UTIs. This is one of the drugs which has recently come up into Indian market, which we can safely use. Zoliflodacin. This is a multi-drug resistant gonorrhea treatment which has come after a long study of a decade, after which we have some treatment for drug-resistant gonorrhea. Now, coming to metallo-beta-lactamases, which are an often challenge for critical care physicians and our patients with severe sepsis, where multiple drug-resistant organisms with multiple highly toxic polymyxin-based regimes often fail to provide a cure. We have Astronam and Avibactam combination, which has recently been approved for MBL-producing enterobacterials, specifically for E. coli and Klebsiella. It is able to combat OXA, NDM, VMP, and AMSI. The Brahmastra of gram-negative sepsis, also called as cefiderocol, has yet to be come to India, but it is still available through the grey market. The cost being a major issue, it actually goes through the mechanism which is also labeled as the Trojan horse phenomena, where it bypasses the most important cell wall component. It bypasses the porins, it bypasses the efflux, it enters through the ion transport of the bacterial cell wall, and it kills the bacteria. It is capable of killing pan-drug-resistant Pseudomonas also. It is capable of acting against Klebsiella and E. coli. Although labeled as the Brahmastra, it obviously also has higher toxicity and side effects, which we are yet to experience in our clinical practice upfront. Coming to gram-positive organism treatments, we have various injectables as well as oral options. However, the injectable options often have a lot of side effects, such as if we talk about vancomycin, it is multiple daily dosing, it is therapeutic drug monitoring, it is requiring an IV access all throughout. Whereas now we have newer options such as dalbavancin and oritavancin, which can be given as frequently as once a day or even once a week. So dalbavancin can be given once a week. The patient comes to the OPD, gets one injection, comes next week and gets another injection, and the treatment dose is complete. Just imagine for osteomyelitis, patients who were getting vancomycin for approximately 2 months or at least 4 to 6 weeks, they can just simply switch to weekly dosing. So dalbavancin has now been expanded to the use for osteomyelitis, sepsis, and even infective endocarditis, very popular for OPD-based antibiotic treatment therapies. Therapeutic drug monitoring is not warranted, and it has obviously much less nephrotoxicity and ototoxicity as compared to its counterparts. Fungus are not riding behind. We have currently we are using echinocandins and amphotericin for our candidemia patients. However, echinocandins resistance is gradually picking up, and amphotericin B, as we all know, is very, very nephrotoxic drug and usually not compatible for a long-term use. Candida auris is emerging, which has high drug resistance to all these antifungal agents. So the newer antifungal agents which are there in the panel are Ibrisafungrib and Fosmanogrepics. These are yet to be introduced in India, but these are effective against echinocandin resistant candidemias. These are also oral options, very good for step-down therapy, very good for home-based treatment monitoring, and much less side effects. When it comes to antivirals, COVID has taught us a wide range of newer antivirals, but I did not touch upon that. I'm here talking about CMV viremia, which is a major threat in our post-bone marrow transplant patients or any cancer patient for that matter. Ganciclovir and valganciclovir are the usual options that we talk about, which also lead to severe neutropenia and nephrotoxicity. However, the newer option which we have, which has recently been launched, is maribavir. This has less myelosuppression, less nephrotoxicity, and is working on CMV, which is resistance by UL97. So, to conclude, we have a ever-long battle which is ongoing since almost a century between adaptive microorganisms which are constantly adapting to the newer innovations that the human is trying. However, if we look back at the last 1 decade, I feel we've fairly done well. We have had small wins. We are moving forward towards newer technology, precision-based and patient-based care. So, we have to be updated. It is a long, evolving, dynamic process. It is never going to stop. The microbes won't stop, and hence humans also should not stop. Thank you so much.
Thank you, Anvita, for a very short and absolutely wonderful presentation. Well, there is still some time. We can really invite some questions.
Yeah, thank you, Dr. Anvita. An excellent talk. So I have one question actually. So what kind of infection, like viral, bacterial, fungal, in which infection you find the drug resistance is more common?
Everything, sir. There is resistance in the doctor who's treating it to accept that the bug is resistant. The bug is resistant from every aspect. The patient is resistant in taking the medicine. So I believe there's resistance at every step. It's a battle.
Okay. Thank you.
Any more questions we can take?
Change to new drug. When you decide?
So, ma'am, it depends on identification of the organism. So, if we have identified the organism, we check the patient's profile. If the patient, depending on the options that we have available, depending on what suits the patient the best is what we're going to offer. Sometimes for the novel agents, the cost becomes a major limitation and we have to resort to the older options. Then in that case, we have to use the older options. But if given the choice, if patient is well tolerable and is able to afford, newer options with lesser side effects should always be preferred.
How often do you identify abdominal?
Ma'am, thankfully we are privileged to work at Gangaram, where our microbiology department is amazing and our culture techniques are amazing, where we can actually identify organisms within 24 hours to 48 hours of a patient coming in. Most of the times, obviously, not every time. So it gives us a headway to guide our therapies.
Thank you so much. I would like to thank the chairpersons as well for this session.
Good afternoon, everyone. I am Dr. S.K. Poddar. I am a practicing surgeon and laparoscopic surgeon in South Delhi in Apollo Spectra Hospital. I am also contesting for the post of president-elect. I didn't want this platform to be used for this purpose, but my opponent has used it, which I think it's not ethical. So that's why I had to come, and I'm also contesting for the post of president-elect. And I have been president of South Delhi branch in 2006. Secretary of Delhi Medical Association in 2014, Senior Vice President of Delhi Medical Association in 2011, grassroots worker. I have not come from up in the sky like my other opponent. So just request you to support my candidature. Come to vote on 8th February, different venues for different branches. Thank you very much.
And now we move on to our last two sessions in this hall. The next session is managing complex abdominal hernias. I would like to request Dr. Suvraj John sir to join us on the dais as the chairperson. Our speaker for this session is Dr. Mukund Khetan. His session will focus on modern surgical approaches and referral timing in complex abdominal hernia cases. Welcome, sir.
Can we have the slides? Khetan is a senior consultant and co-chairman of the Institute of Minimal Access Surgery, and he's going to be elaborating on complex hernias and their modern management.
So, thank you. I'll welcome you on behalf of Sir Gangaram Hospital and Institute of Minimal Access Metabolic Surgery at Sir Gangaram Hospital. So, can I have my slides, please?
Hernia is a very common problem, and I'm sure you see that almost on a weekly basis.
Yeah. So it's basically like when I started, we started management of hernia by laparoscopic way back in 1992 when the laparoscopy was introduced to the surgical fraternity. At that time, we were managing the simple hernias, maybe inguinals or smaller ventral hernias of late. And then with the invent of the newer techniques, the technology and the technical tools, we are able to manage these complex hernia in the same way. Can I have my slides, please? So what do you mean by the complex hernias? So we see in the daily practice, you all must be seeing a different sort of hernias. So hernias can be complex depending upon the different situations. One could be from where they are, location of the hernia. So location, the hernias which are closely located to the bony boundaries, like in the subcostal hernias, like the subxiphoid hernias, those after the LSCS or maybe the hysterectomy, that is the phalansteal scar hernias, the lumbar hernias. So they are all hernias which are boundary wall hernias are labeled. Then those hernias where there are skin infections. So there is a skin infection or a previous infection in the laparotomy wound. So those all hernias are also qualified into the complex hernias. Then the hernias which are being repaired earlier, like the recurrent hernias. So we see patients who have been repaired maybe twice or thrice, either by open method or laparoscopic method, and they are coming back to us with again a large hernias. So these are the hernias which are labeled as a complex hernias. Then there another subset of patients who are lingering on to the disease, like they are waiting for the hernia to get better by their own, and they come up with a second abdomen. Like most of the abdominal contents are lying outside the abdominal cavity. So those are the hernias which we label as a loss of domain hernias. So and then the hernias in an immunocompromised patients, then the patient patients with an ileostomies or a colostomy. So those patients do develop some sort of an parastomal hernia. So those all hernias are labeled as a complex hernias, and we in our practice see all sort of hernias which we have to manage them pre-operatively. So these are the patients which require some sort of an pre-operative optimization also. So you have to define the abdominal wall anatomy, the quality of the contents. So the quality of the contents have to be seen. So a pre-operative one is assessment of the patient, the assessment of the hernia. The second is the pre-operative optimization. So we have to do a pre-operative assessment. So the pre-operative assessment is by three way. One have to have a good history of the patient, like what all has been done earlier, if the patient has undergone a previous hernia surgery, if the patient has been operated by a laparotomy. So whatever surgery earlier has been done, a good history, and then the clinical examination, and then comes a CT scan. So we are fortunate at Gangaram Hospital, as Dr. Anurag, you must have listened her talk, that the AI is also helping us in guiding the same. So we have to do a pre-operative assessment by a CT scan. So CT scan not only gives us the size of the hernia, it gives us the overall picture, what are the contents, what are the quality of the contents, what is the quality of the muscles lying over there, and then what is the status of the previous mesh, if the patient has a previous mesh repair, whether it is an intra-abdominal mesh, a onlay mesh, or a... So if you can see, the patients come with these all hernias, and a CT, like a CT reconstruction gives you the overall anatomy, how much gap is between the two recti, what is the width of the length of the hernia, and then the different hernias, like these are the all boundary wall hernias, then these are complex hernia, almost like a second abdomen, a mesh is exposed over there, and there is a scarring over there. So when we do abdominal wall reconstruction, these are all complex hernias. They cannot be managed by a simple only repair or by a simple hernia management. They require some sort of an abdominal wall reconstruction, where we have to reconstruct the components of the abdominal wall. So when during our medical student life, we do learn about the medical abdominal wall anatomy, but we are never utilizing that as a surgical anatomy. So now we are relearning that abdominal wall anatomy so as to do a better job doing abdominal wall reconstruction. And are different planes where we can place the mesh either by open method or laparoscopically or maybe robotically, so as to reduce the recurrence chance and the surgical site occurrences over there. So it can be an overlay mesh, it can be an intramuscular mesh between the two oblique muscles, it can be a sublay mesh below the rectus muscle or the transversus abdominis muscle, or it can be another sublay where it is a pre-peritoneal mesh, or it can be an intraperitoneal mesh, which is a common method of managing the ventral hernias. So we have evolved. So the paradigm shift is from onlay mesh to an inlay mesh to an underlay mesh and then the sublay mesh. That is an extraperitoneal mesh. And the approaches have shifted from open approach, then comes the era of laparoscopic approach, then the laparoscopic and hybrid approach wherever we need, and then the robotic platforms has come up, adding on to ease and getting a better outcome in these hernias. And similarly, while managing these hernias, when we initially do these hernias, we don't close these laparoscopically. And then comes the era of a laparoscopic IPOM plus. That is when we close the defect laparoscopically. And then, but then when we close these defects, these are being closed under tension. So then we have to do a tension-free repair. So when the herniology science says that whenever you are approximating any muscle or any aponeurotic part, that it has to be under physiological tension or a tension-free repair so as to prevent recurrences. And then comes the role of a component separation. So we have to divide the different components of the abdominal wall so as to do a good approximation of the defect and placing a mesh in a pre-peritoneal or a retrorectus plane. And that's the evolution of the procedure. That is a IPOM, that is an intraperitoneal onlay mesh repair. Then comes a defect closure, that is IPOM plus. Then we switched on to a retromuscular repair, that is called as ETAP retromuscular or Reeves-Topa repairs. And then adding on to will be a component separation if required, if the defect is larger, and a large piece of prosthesis that is called as a giant visceral reinforcement of the abdominal sac or visceral sac. So what are the principles when we talk about these complex hernias? So there are principles of abdominal wall reconstruction. It has to be a tension-free approximation of well-vascularized tissues. So in the open era, when we do a debridement, the tissue, we have to see whether those tissues are viable or not. Then the reconstruction of the linea alba. As the backbone is the central part of the vertebral column, the linea alba, that is the central part, that is the central tendon of the abdominal wall. So it has to be reconstructed. We have to approximate the two recti in the midline. And then this all repair has to be reinforced with a suitable prosthesis and preventing the surgical site occurrences. As I said, the assessment has to be done, a preoperative optimization, a CT scan is must. So you can see these CT scans. So we always learn how to read our own CTs, and with the help of AI and with the help of the radiology department, which is excellent at our Gangaram Hospital, we are able to see the smaller situations where maybe an infected mesh, we can see the minute obstructions, we can see the minute strangulations over there, and where the mesh is lying there. So as we have to be careful while performing these surgeries. And most of these patients are, God is so kind that we are able to manage them laparoscopically or maybe with the help of a robotic platform. So these are certain steps. So I'm not going to go into these steps, but once our surgical reconstruction is completed, then we have to see for an adequate hemostasis, because there's a potential space we are going to create in the abdominal wall, and then the mesh has to be measured. Mesh has to be, because we are introducing a mesh through a 12 mm trocar, maybe about a 30 or 40, 30 to 45 centimeter size of the mesh can be easily introduced into the retromuscular plane. So we have to learn how to deploy these meshes, and if required, we drain these areas. And see, these are certain patients where the whole of the abdominal contents are lying outside the abdominal cavity and the skin is almost hanging all up to the knee. So these patients require a preoperative optimization. These are called as loss-of domain hernias, where more than 20 or 25% of the abdominal contents are lying outside the abdominal cavity. So these have to be optimized preoperatively by either a Botox injection or maybe a pneumoperitoneum or in the initial part, preoperative part, and then we have to subject them to the surgical intervention. And there are certain patients in subset, and we got those patients mainly from our obstetric and gynecological friends. There's a patient with a large divarication within a small umbilical hernia, and they came with either constipation problems or backache problems or maybe a parturition problems. So these patients have to be managed either laparoscopically or with the help of our plastic surgery team. We do a sort of an abdominoplasty associated with the repair of these divarications. Then you can see a battered abdomen. The whole abdomen is scarred. Somewhere to enter. With the advent of the newer techniques, the newer tools, and with the practice, we are able to manage these most of our patients laparoendoscopically. And the second abdomen, you can see the almost more than, this is a primary hernia. So patient was waiting for the hernia to go on its own, and is a 70, 72-year-old male came with a second abdomen. And another patient, the obese patients, especially the obese patients, as we have already talked about the obesity, the fat in the liver and all that. So these patients are more difficult to manage hernias in the obese patients or those patients with comorbid conditions. A large recurrent hernia, so a female patient, most of the 1/3 of the abdominal contents are lying outside the abdominal cavity. Then these smaller hernias, maybe umbilical hernias or umbilical hernias in CLD patients or post-CABG hernias. So we see a lot of post-CABG hernias which are in the hypogastric, in the epigastric subxiphoid areas, and which are difficult to manage by laparoscopically when we try to do an intraperitoneal onlay meshes. So these are better managed in a retromuscular plane or a pre-peritoneal plane by abdominal wall reconstructions. So I'm not going into detail into the procedure details because these are more technical things. And there's a number of now publications. We are fortunate at Gangaram, we have our own publications managing the midline primary hernia, managing the lateral hernias, which are more complex hernias, and we have our own publications for that. So in the end, what I like to say is the management of these complex hernias have taken a paradigm shift from open era to a laparoscopic era, from an intraperitoneal mesh to an retromuscular mesh, adding the component separation techniques to them. And then you have to take a thorough history, a thorough clinical examination of the patient is important, and an investigation, especially the CT scan is must in all these patients to assess the severity of the hernia and to plan what surgery you are going to give that patient. And these patients require a better preoperative optimization and an intensive perioperative care. So it's not only a preoperative optimization, many of these patients, especially with larger hernias, recurrent hernias, require a better intensive perioperative care. And for the surgeon, a surgical expertise and a thorough knowledge of the procedures is required to manage these complex hernias for an optimal outcome. Thank you for your patience hearing.
Happy to take questions. Thank you for keeping to time. Any questions?
No, so the hernias, like those hernias, as I said, that complex hernias, so we have to see it is related to location. Location is making complex, or the previous surgery, or whether it is a loss of domain, whether the previous mesh is exposed, whether the skin or the wound infection or wound dehiscence is there. So depending upon them, you can give them some sort of an management, non-surgical management. But as I said that when the hernia is there, it's like a hole in your cloth. So it cannot be going on its own. You have to repair it. So you have to pre-operatively optimize them by taking a cardiologist advice, by taking a physician advice, and then you have to tell them the risk assessment also. So you have to do a risk assessment, what benefits they are going to get by surgical intervention, whether there is any life risk or not. So those all, and then we can give you them some garments, and then a pre-operative optimization by a physician is must. But there is no as such surgical treatment which is going to take care of their problems.
Yes, ma'am.
Yeah. So those small hernias, definitely if they are not going on their own by 1 to 2 years of age, definitely will require some sort of an intervention if they are causing problem, because they are primary hernias until they are larger hernias. So suppose the defect is more than 1 to 2 centimeter. Remember, the defect might be 1 or 2 centimeter only. So we have to look into the defect size rather than the hernia sac size. So if the hernia sac is increasing in size, causing problems, whether the bowel problems or some other problems, then they need repair. They can be managed surgically without mesh. So those in the growing age group, that is up to 13, 14 years of age group, will require a non-mesh repair. So a suture repair will be enough. Yeah, definitely. Yeah, so the hiatus hernia is basically a hernia between the abdominal cavity and the thoracic cavity, and they are very common in today's era, maybe a grade 1 to grade 2 hiatus hernias along with the gastroesophageal reflux diseases. So we have to see by endoscopy what is the size of the hiatus, whether there is an insult to the esophagus, and depending upon the size of the hiatus, the type of the hiatus hernia and the associated reflux disease, one can take a call whether a surgical intervention or a medical intervention is sufficient for that patient. Thank you.
Thank you so much, sir. And now as we move on to the last session in this hall, I would like to request Dr. Arya, the Senior Consultant in the Department of Anesthesia, to join us on the dais. So please. And our speaker is Dr. Suviraj John, and he's going to talk about a functional approach to treating anorectal prolapse.
Thank you very much. I believe I'm between you and your lunch. So what we'll make sure is this talk is about you. I'm going to teach you about roughly 5 points, how quickly you can diagnose a case of a pelvic organ prolapse, especially the GIT, gastrointestinal system, how well you can assess it, counsel the patient, because most likely the patient's going to come back to you. We'd like to send the patient back to you to follow up the patient, because this is often a chronic disorder. Right. Pehli baat. Patient presents to you with mass per rectum. What is the first thing you're thinking when patient gives you the history? What is the first thing you're thinking? Piles, hemorrhoid, good. I don't think you're thinking about this, all right, when the insides are coming out, right? And this is something we're seeing now increasingly. It's underreported in India. And they often suffer in silence. It'll be useful if you can do a simple cursory observation and maybe a digital examination to diagnose it quickly and send it to someone, a team that deals with this exclusively. Now, if you look at prolapse, what are the two kinds of prolapse you can think of? From whatever you know. Great, that's one way of looking at it. So it's irreducible, you think it's likely larger, it's got the full thickness rectum coming out. Smaller, you may think it's mucosal prolapse. But what I'd like to introduce you is a fine difference. One is a full thickness rectal prolapse and one's an internal one which may pop out and go back inside, all right? And the difference is the quicker you diagnose the smaller category, you don't leave them go into full thickness and irreversible pelvic damage. Remember, all of us, we have to be really grateful every morning or evening we go to the bathroom, have a perfect defecation experience and go back to our work or our personal lives. This is a luxury. For many people, they suffer. Story starts where there's about 6 to 8 centimeters from the anal verge, the rectum into Sepsis. Patient doesn't notice it. Initially, they have obstructive symptoms, and then the rectum comes out, all right? If we can catch this earlier, it'll be great. That's where you come in. I've made this slide. It took about an hour yesterday to make it. Please recognize patient come with multiple symptoms. The commonest one is mass per rectum and anal incontinence. By the time a patient complains, you ki doctor sahab kapde bhig rahe hain, please, that should raise a red flag in your mind. Quickly evaluate the patient. It could be something else too, but worry about a pelvic organ prolapse because it can damage your pelvic floor. Please remember, any history more than 5 years can lead to a higher rate of recurrence, and somebody who leaves it longer can cause irreversible fecal incontinence because of damage to the sphincter and the pelvic floor. All right, and in 1/3 of cases associated with urogenital incontinence or prolapse also. So a full examination of the pelvic floor is very important. Now, once you refer it, we do a full pelvic floor and a pelvic organ assessment, both history-wise, clinical examination, as well as focused investigation, endoscopy, high-resolution manometry, and most importantly, I'd like to tell you that we have now a functional imaging. The radiologist talked about this. Today, we have dynamic MRI. What we did in the past with a deficogram with barium, we can do dynamically with an MRI, and this gives us not only structural information, gives you functional information. Once you correct the structural abnormality, the function usually returns. So things we're looking for is degree of prolapse, descent of the pelvic floor, as well as concomitant other organ prolapse or other pathology. So once we check all this out with the manometry and the endoscopy, we can now reach the decision-making stage. You can take a photograph of this if you'd like, or I can share this with you later. So depending on the grade, there are 5 grades. Obviously, when you reach stage 5 or stage 4, you have to operate. But please remember, the trick is to catch this as early as stage 3, right? That we can only do with a dynamic MRI, and now we have it. It's freely available in most centers. So the moment you suspect a pelvic organ prolapse, it'll be very useful to just get a dynamic MRI done and take the CD-ROM with the DICOM files and send it to a team like ours, and we'll take care of it. So put it simply, a history examination along with dynamic MRI, high-resolution manometry, and a colonoscopy will help you decide what to do. Now, incontinence as well as obstructive symptoms are a challenge. So it's not only reconstructing the pelvic floor and the pelvic organ location, we have to give them functional competence. So that's our real goal of surgery. This is a functional surgery, and that's where the trick is. You have to understand all the complexities. It's a multivariate analysis. We have now both abdominal approaches, perineal approaches. Perineal approaches largely for old high-risk patients coming in emergencies. Abdominal approaches are the choice approach because they have much better long-term lower recurrence rates. Starts with simple suture rectopexy to mesh rectopexy at the anterior posterior, along with resection if there's a large redundant sigmoid or colon. All right. I won't get into nuances, but robotic and laparoscopic surgery gives us faster recovery, lower adverse complications to other organs, as well as a quicker return to work. And I think today with the high 4K resolution with 3D, we can do a much better repair. Like I mentioned, a simple suture rectopexy for early prolapse or grade 3, grade 4 internal intussusception. And a posterior mesh rectopexy was the classical one. But in the presence of constipation, right, you have to concern because constipation can worsen once you do a posterior rectomexy because you often cut the lateral pedicles. So thus we have the latest iteration. The ventral rectopexy, I wouldn't call the gold standard, but it's near to a gold standard. It's a nerve-preserving rectopexy. We don't disturb the pelvic nerves, the sympathetics or the parasympathetics. And because it's a nerve-sparing one, the incidence of constipation is much lower in this, right? Overall, all of them have good results and similar recurrence rates. But with the increasing experience with ventral rectopexy, we see excellent return to gastrointestinal function. Lower rates of incontinence, much better colorectal quality of life, and this has been studied by multiple studies. Look at the p-values, very, very strong. And whether you do it for primary or recurrent prolapse, we get a lot of recurrent cases, people who had posterior mesh rectopexy, they come back to us, we do a ventral mesh rectopexy. It's a wonderful option, laparoscopic or robotic, for people who have primary or recurrent prolapse. Today now it's in the guidelines of the American College of Surgeons for colorectal surgery. And thus, you know, we counsel patients very detailed. You can take a shot of this slide. This is a summary slide, right? Somebody presenting you mass per rectum, incontinence, digital examination, good history, difficography or MRI today. Grade it. Grade 1 and 2, start with lifestyle management, biofeedback, follow them up. People don't improve, counsel them regarding surgery, send it to a team that deals with pelvic floor abnormalities. Grade 3 and 4 is the real trick. We really need your help. Do the MRI early. It's not very expensive. It is expensive, but not as expensive as it used to be. Obviously, grade 4, it's staring at you, you have to operate. If you can catch it at grade 3, 4, we can give them excellent quality of life, pelvic floor competence in terms of avoiding incontinence as well as obstruction. And of course, depending on their age and fitness, we choose the type of procedure and the approach. Thank you very much. If you'd like any questions, I'm happy to take it. So that's a potentially reversible one. As a patient gains fitness, especially in children, it goes back. We're looking at people who are older, especially women above 50, multiparous, or people who have obesity. This is becoming more common now, resembling the West. So the trick is if somebody comes to you with a mass per rectum or even obstructive defecation syndrome, what you call, you have trouble, they're pushing and this still doesn't come out, get a dynamic MRI. This is the secret today. So functional imaging along with the functional surgery is the way forward. Thank you.
Thank you, Dr. John, for a nice depiction and detailing about the anorectal problems, especially the prolapse problems. And I think you must be aware of like how to diagnose and when to refer and what all is to be done for better management of these patients. Thank you, Dr. John.
Thank you so much, chairpersons and speakers, and thank you, audience. We are going to close this hall now, and I request everybody to join us in Hall A in Jacaranda, where the inauguration function is going on. That will be followed by a lucky draw for all the audience members, so please join us. The sessions after lunch will be conducted in Jacaranda only.